and it's noon. So unless anyone,
Oh, do you want to start letting them in now?
That's what I was suggesting. Yeah.
Good morning, good afternoon, everyone. I'm Kathy Bernard, founder of the Save Your Skin Foundation. It is with pleasure that Sharon Clark and I welcome you to the 7th annual Patients Redefining the Future of Healthcare in Canada Summit, hosted by Save Your Skin Foundation and the Canadian Psoriasis Network. I would like to begin by acknowledging the Indigenous peoples of all the lands of each of us is on today. While we meet on a virtual platform from coast to coast to coast, we acknowledge the ancestral and unceded territories of all the First Nations, Inuit, and Métis peoples that call these lands home. We affirm our commitment and responsibility to improving our own understanding of our local Indigenous peoples, including First Nations, Inuit, and Métis, and to improving relationships. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past that continue, and to consider how we can each, in our own ways, move forward with meaningful efforts of reconciliation. I didn't expect to be saying this again this year, but I also want to take a moment to remember those who have lost their lives over the past year and this pandemic overall, directly or indirectly due to COVID-19. I send well wishes to those who are ill and wish them a speedy recovery. I sincerely thank first responders and other healthcare workers who have and are still working long, difficult hours on our behalf across this country and in other countries as well. Never have the issues of the sustainability and effectiveness of healthcare systems and delivery been more in the forefront of people's minds than they are today. Never have patients felt more that they need and are entitled to a meaningful voice in the future upon which their welfare depends. Thank you to our sponsors, AbbVie, Amgen, AstraZeneca, Bristol Myers Squibb, Novartis, GlaxoSmithKline, Merck, Roche, Leo Pharma, Pfizer, and Janssen for making it possible for us all to come together virtually today. Thank you to IMC for supporting the summit working groups, and thank you to Axon for its technical support. Let's be clear, problems with the healthcare system have existed long before this pandemic. The pandemic has exacerbated them and probably created some new ones. This summit will explore these issues and potential solutions, integrating patients' experience as key to developing and implementing these solutions. Sharon, over to you.
Thank you, Kathy. This summit recognizes the need for real change, and in previous years, we have worked together to determine how this could be achieved for the benefit of all patients. We have concluded that a system resting on a foundation of patient-reported outcomes, and containing good data collection will lead to integrated models of care that will ensure that specific populations in our society meet the healthcare, receive the healthcare they need. Our collective experience during the pandemic is an important overlay to these pre-existing underlying problems. It requires us all to look ahead with vision and the courage to embrace real change. How do we, as patients and patient allies, contribute to value-based health systems that ensure needed access for all people across Canada? How do we ensure that those who have often been left out of proper planning and implementation for our health systems are included? How do we ensure Indigenous people are included and have their own distinct voices heard in a meaningful way? And perhaps most importantly, how do we bring together federal and provincial and territorial decision makers to collaborate and to bring in other healthcare stakeholders rather than pointing fingers and laying blame? These are questions of utmost importance for patients and people in general at this time. Over the course of the summit, we will explore these questions with a host of keynote speakers and panelists. We will take in their wisdom, and as in every other year, we will develop and amend existing action plans in response to the challenges. So with those words, enjoy the summit, and together I know we will share and rebuild anew. Thank you.
Thank you so much, Sharon and Kath. Just give me 1 second here. I am happy to be here again this year. And I'm just, there we go. Hopefully you can all see this slide. Going to spend a couple of quick minutes providing a bit of some level setting and overview of what's to come. So we're very excited today. Our theme is Echo Pandemics, the Way Forward. And I will touch on our agenda for the day in just a second. Hopefully many of you or all of you can join us again on Wednesday, where we will dive into echo pandemics and the way forward in Indigenous health. And we have an incredible keynote and wonderful speakers for day 2. And on Thursday, we move into more of the solutioning and the thinking around value-based healthcare. What does that mean? And how can these elements of better health data, integrated models of care, patient-reported outcome and experience measures, how can they contribute towards healthcare systems that are beyond resilient, more than just returning to their original shape, but actually receiving shocks from crises like this pandemic and being able to learn and improve what some people talk about as a learning health system as well, or as anti-fragile. So that's day 4 on Thursday, November 17th. And on Friday, November 18th, for all of our individual patient and caregiver participants, as well as those of you who represent patient or caregiver or citizen groups, we have a patient planning session for about an hour and a half on Friday, in which we will be rolling up themes that we've heard throughout all of the days and taking what you guys are sharing through the breakout groups and the themes coming through there, reflecting them back and sharing also at a high level what's been happening with the 3 working groups focused on data, proms, prems, and integrated models of care, and getting a sense of, what do we need to be doing together going forward? Have we got the right work for the working groups? That kind of thing. So really some action planning as patients and caregivers together. So hopefully you can join us for that as well. Today, my great thanks to our co-organizers, to Kathy, to Sharon for the opening remarks, and then we will have Louise get everything started. And we're so excited for our 2 keynotes. Our first will be the Honorable Carolyn Bennett, Federal Minister of Health and Addictions, Associate Minister of Health. And then she will be followed by Richard Jock, Chief Executive Officer at the BC First Nations Health Authority. There will be moderated Q&A with each of these keynotes. And then we're going to move into a panel conversation, series of short presentations, conversation, hearing from different experts with expertise in different populations who have been disproportionately impacted through the pandemic and through the echo pandemics, resonating, the effects of what COVID-19 has done to our healthcare systems and to our society more broadly. So Zoe Dodd, who has expertise in harm reduction and substance use policy, Dr. Sandy Sadev, an oncologist, Laura Tamblin Watts, who is an expert in seniors, and Rachel Mannion, bringing her expertise in chronic disease, specifically different skin conditions. And then after the Q&A coming out of those, we will move into our breakouts. And hopefully you can stay with us for those breakout sessions where you have a chance to reflect on everything you've been hearing and learning. And we will, as I mentioned, actually take the themes of what you're reflecting here and bring them to our action planning session on Friday. So events like these, no surprise, take many incredible people and organizations to pull them off. And so I'd like to thank a number of different groups, starting with the 2 organizing patient groups, the partners who make this possible, Save Your Skin Foundation and the Canadian Psoriasis Network. And we would also like to thank, of course, the sponsors and in-kind supporter who make all of this possible. So I know the sponsors were already thanked by name by Kathy. So thank you so much from the bottom of our hearts, and also our in-kind supporter Axon, who has made all of the technical side of this possible. And if you are having any tech issues during any of the meetings, they're the people who will be helping. So thank you so much to the Axon team. Big thanks to the Summit Organizing Committee members who worked diligently throughout the year to pull together 4 webinars and this event itself. So Sharon Clark, Louise Binder, Antonella Scali, Chantal Burrows, Kathy Bernard, Taylor Tomko, Marianne Gagnon, Liz Bono, Amy Rosewald, who's helping out with social media today, and myself. Pat yourselves all on your back, and thank you so much. Thanks to all of the members of our 3 working groups, and especially their chair people, who are Eva Villalba for the Proms and Prems group, Shanil Pathak for health data, and Louise Binder for integrated models of care. Thank you to all of the volunteers who are facilitating our breakout groups at the end of the first 3 days. So Stephanie, Lori, Megan, Martine, Cheryl Ann, Joanna, Antonella, Amy, Taylor, and Eva, big thanks to you. And last but certainly not least, thank you to our French interpreters, Ciro, Hamid, and Joseph, and our French translator, Rachel Fecteau from Traduction Rhizome, who have supported us so much in order to make this more accessible to our Francophone colleagues and friends. A little bit of housekeeping, during plenary, please keep your lines, your video off, please mute yourself. However, if you would like to ask a question at any time, just put it into the chat and we'll be monitoring that for questions, and we'll bring them into the moderated Q&As. The session is being recorded in both English and French, and we will, if everything goes well with the recordings, we will make them available through YouTube after the fact. To access the French interpretation, click on the world icon at the bottom of your screen, then click mute original audio, and then select French. I already mentioned, if you have a question at any point, use the chat. And if you have any technical difficulties at any point, contact Axon Technical Support using the chat function, and they will do their best to assist you. Please do share any ideas that are inspiring you, that you're hearing about during the summit, using your social media accounts, and feel free to use, please, I encourage you to use one of these hashtags to let people know that you're part of this conversation online, and so we can see what each other are saying as we are hearing and learning and reflecting on the content. And we will send out brief evaluation surveys after each day of the summit. Please do tell us how we're doing and how we can improve. It means a lot to us. And there is an event report that will be prepared both in English and French, and it will be ready by the end of this year. And we will share it with all registrants and via our webpage on the Save Your Skin Foundation website. And now I am pleased to introduce my colleague, Louise Binder, who's the health policy consultant at Save Your Skin Foundation, to welcome our first keynote speaker for today.
Hello, in whatever time zone you may be in Canada today. As you join us, I certainly would like to add my welcomes to those of our 2 of our co-chair steering committee members. And I must say that I'm amazed that the little idea that a few of us had to do a bit of patient education on health policy 7 years ago has turned into what is really quite a fascinating and unique series of summits, I would say. And so today, I am sincerely honored and pleased to present our opening keynote speaker, who will welcome us to the summit today, the Minister of Mental Health and Addictions and Associate Minister of Health in Toronto St. Paul's riding, the Honourable Carolyn Bennett, who has been elected to the House of Commons since 1997, many times, being re-elected in 2000, 2004, 2006, 2008, 2011, 2015, 2019, and of course, most recently, 2020. She was previously the Minister of Crown Indigenous Relations, the Minister of Indigenous and Northern Affairs, and the Minister of State for Public Health. Prior to re-election in 1997, Minister Bennett was a family physician and a founding partner of Bedford Medical Associates in downtown Toronto. She was also an associate professor in the Department of Family and Community Medicine at the University of Toronto. Her fight to save the Women's College Hospital of Toronto inspired her to enter politics. And I was actually working with Carolyn on the issue of the closing of the hospitals at that time. Minister Bennett is an active representative of Toronto St. Paul's. She's organized over 75 town halls, quarterly meetings, information sessions, and special activities for her constituents since 2000. She and her office have assisted hundreds of constituents with their immigration, tax, pension, or employment insurance concerns. Minister Bennett speaks passionately about Canada and Canada's participation in the democratic process. She advocates for health, the environment, women's involvement in politics, and persons with disabilities. She is also known for her strong support of Israel. In 1986, she received the Royal Life-Saving Society's Service Cross, a Commonwealth Honor Award recognizing her more than 20 years of distinguished service. In 2002, she was the recipient of the coveted Eve Award for contributing to the advancement of women in politics. And in 2003, she received the first ever Champion of Mental Health Award from the Canadian Alliance on Mental Illness and Mental Health. She was also the first recipient of the National Award of Excellence for outstanding leadership and dedication to injury prevention and safety promotion in Canada. And indeed is also the co-author of Kill or Cure, How Canadians Can Remake Their Healthcare System. Minister Bennett and her husband, Peter O'Brien, a Canadian film producer, have two sons, Jack and Ben. Minister Bennett was unable to join us virtually today, except by recording, but she has recorded what I hope you will find to be as amazing a presentation as I did when I saw it for the first time. And then we'll answer some questions that were put by some of our participants to Minister Bennett prior to this. She also will be available if we want to send questions to her after this event. And her presentations will be followed by a few reflections on what she has said, given this important, profoundly important issue of mental health and addictions. And we'll open it up to the group, obviously, online for comment and reflection as well on what she's had to say, and indeed how it might create some thinking about our role as patient representatives moving forward in this area. So with no further ado, it's my honor, the Minister of Health, Minister of Mental Health and Addictions, and Associate Minister of Health, the Honorable Carolyn Bennett.
Bonjour et bon après-midi à tous. Avant de commencer, je souhaiterais reconnaître que je vous parle aujourd'hui depuis Ottawa, qui se trouve sur le territoire traditionnel non cédé du peuple algonquin Anishinaabe, qui vivent sur ces terres depuis des temps immémoriaux. Thank you all for being with us today, and welcome to the 7th annual Patients Redefining the Future of Healthcare in Canada Summit. I really wish I could be with you and Louise, and I know you're just going to have a great time. It is so great. The patient is front and center for this summit. Sir William Osler said the good physician treats the disease, the great physician treats the patient who has the disease. But we know that Sir William also said that the patient is the very best teacher. dont les rassemblements comme celui d'aujourd'hui pour partager des expériences de vie, des pratiques sages et des expériences de ceux en première ligne, ainsi qu'en s'écoutant les uns les autres pour faire avancer les patients et le système en même temps. I want to thank Dr. Louise Binder for organizing the summit and for inviting me to speak, but for just being such an inspiration throughout my whole time in Parliament. As you know, this year's summit will build on the themes from last year, including exploring the ongoing barriers and systemic issues in the health systems experienced by patients in Canada that have become starkly clear in light of the COVID-19 pandemic. The 2022 theme of COVID-19's echo pandemics, the way forward, will expand on the idea of moving healthcare from beyond the concept of resilience. As we move forward through our recovery phase, resilience will play a key role in how we continue to adapt and adjust our healthcare systems to better serve Canadians everywhere and better prepare for future crises. As you know, in 1986 at the Ottawa Summit, the Ottawa Charter said that we had to move beyond healthcare systems to systems for health, and only patients and citizens will be able to say what they need and when they need it. Shortly, you'll be hearing from Richard Jock and other incredible people in the coming days like Sheila Watt and Terry Morrow. The topics you will cover, including mental health, healthcare, Indigenous health, is pivotal in getting this right. I look forward to seeing the action plan that will come out of this summit that builds off the great work that's being done in the past, like the Declaration of Patient Data Rights. Parce que, comme nous le savons tous, les dernières années ont été difficiles pour plusieurs raisons. Isolation, financial and employment uncertainty, and disruptions to daily life have left many people across Canada struggling to cope with stress, anxiety, depression, and loneliness. Yet, when so many more of us needed support, support was all too often out of reach. Care for those struggling with their mental health and substance use has not been consistently available across the country. And when it was available, Canadians often faced long waiting lists, way too long. Many communities, including the Black, 2S LGBTQIA+, multicultural and Indigenous populations, were disproportionately impacted. Tristement, ceux qui étaient mal desservis par notre système de santé et de santé mentale avant la pandémie souffrent encore plus maintenant. COVID-19 pushed an already stressed healthcare system to its limits, and we know it is still a challenge for Canadians to know where to look for help, to find the right help, and to be able to access that help right away. This summit has a large focus on Indigenous healthcare, so it is well recognized here that Indigenous populations in Canada are at a higher risk of experiencing mental health issues and the ongoing issues of stigma, the overdose crisis, overuse of alcohol, as well as the gaps in awareness, education, and access to mental health and substance use services and supports, which are unacceptable. We need your help to close those gaps, improve outcomes for members, and prevent the inequities faced by many members of all our communities. We must also recognize the impact of social determinants of health and the work we need to do together to keep people well, physically, mentally, emotionally, and spiritually, not just patch them up when they get sick, as Tommy Douglas told us and as the medicine wheel teaches us. Plus de la moitié des Canadiens sentent que leur santé mentale s'est détériorée depuis le début de l'épidémie de la COVID-19. Over 70 years ago, Canadian war veteran Dr. Brock Chisholm, the first Director General of the World Health Organization, stated, "Without mental health, there can be no true physical health." My mandate as the first ever Minister of Mental Health and Addictions includes developing and implementing a comprehensive evidence-based plan for mental health, as well as advancing a strategy to address substance use issues in Canada, including the heartbreaking overdose crisis. I believe that Canadians should be able to expect the most appropriate care in the most appropriate place by the most appropriate provider at the most appropriate time, and that includes virtual. And to achieve this, mental health must be treated as a full and equal part of our universal healthcare system. The Standards Council of Canada is working with us as well as our provincial and territorial partners, to develop national standards for evidence-based mental health and addiction services on the priority areas identified with our provincial and territorial colleagues. Ce travail est soutenu par 45 millions sur 2 ans et nous sommes encouragés par le progrès incroyable sur des normes nationales pour les services intégrés à la jeunesse qui sont maintenant adoptées par toutes les juridictions. Over the past year, we've heard clearly from partners in community that we must work together on the way forward for health and healthcare in Canada. Last week, Minister Duclos and I met with all the provincial and territorial ministers, health ministers in Vancouver, to chart that way forward, particularly with a focus on health human resources, including the expansion of the concept of the mental health workforce. They also were very keen, as your theme is today, to focus on data. We have to know what's working and what's not. And we have to listen to patients in order to determine that. When it comes to Indigenous communities, when working together, we must remember that the Indigenous population is highly diverse in their identities, lived experience, and degrees of connection to culture. It's essential that we provide access to culturally safe, trauma-informed care and supports. Perhaps we need to move forward with the two-eyed seeing teachings in mind, learning to see from one eye with the strengths and Indigenous ways of knowing, and from the other eye with the strengths of Western ways of knowing, and to use these both eyes together for the benefit of all. It is also clear that the secure personal cultural identity, not only for Indigenous people, for all of the people who live here in Canada, is essential to people making healthy choices. That is their resilience, it is their self-esteem, and we need to make sure that that is part of our solution. Il est clair qu'en matière de santé mentale et de consommation de substances, nous devons adopter une approche holistique en fournissant une variété de services, incluant des services de réduction des risques. Because while the pandemic exacerbated the gaps in mental health supports available to Canadians, it also accelerated the use of virtual care options to help expand the availability and flexibility of those services. And in April 2020, we launched Wellness Together Canada. This online portal that I hope a lot of you have had a look at has served as an invaluable connection for many Canadians, allowing them to get the help they need even when they could not leave their homes, or use it as a stepping stone to receive advice on where to find more specialized care and how to augment self-care. The portal's companion app, PocketWell, also ensures Canadians have access to the mental health and substance use services they need, no matter where they live. Nearly 3 million individuals across Canada have accessed the portal in over 8 million web sessions, and the app has been downloaded over 30,000 times. Les commentaires des utilisateurs du portail ont été très positifs. The next and final issue I want to discuss related to today's summit theme is the ongoing overdose and toxic drug crisis, which we all know has been compounded by COVID-19. This devastating crisis is one of the most serious public health challenges in our country's recent history. It is widespread and pervasive, and has taken loved ones from families and friends in our cities, suburbs, towns, and rural communities. From Cape Spear to Haida Gwaii, from Carcross to Windsor, in southern Ontario, people are dying. At the height of the pandemic, restrictions and gathering limits made it more difficult for people who use substances to access vital harm reduction services, treatment, and other supports. And to make matters worse, the illegal drug supply was made even more toxic. The addition of benzodiazepine is making overdoses more difficult to reverse, with naloxone and detox and withdrawal way more unpredictable. Tragiquement, des milliers de personnes sont décédées dû à cette pandémie parallèle. This crisis can no longer be characterized by something that only happens with those people in the downtown east side in Vancouver. It's happening to people we know from all walks of life. It's an us problem. And we are so grateful to groups like Mom Stop the Harm for their courage in telling the stories of the loved ones they've lost and breaking through the stereotypical portrait of people using drugs. There is an emerging consensus that we have to do more to reverse this devastating trend, to save lives, and bridge the gaps that exist in our health systems so that more people can get the care they need and no longer are the barriers of ideology. L'année dernière, le ministre Hadju a nommé un comité d'experts pour répondre à cette crise. Ils ont demandé des actions audacieuses et des changements significatifs de politique. One example of that bold action and significant policy change we are trying to make is when BC requested an exemption under the Controlled Drugs and Substances Act so that individuals 18 and over in the province will not be subject to criminal charges for personal possession of small amounts of certain illegal drugs. This past May granted that request, making it clear that our government sees and is treating substance use as a health issue, not a criminal one. As of January 31st, 2023, adults 18 and over in British Columbia will no longer be subject to criminal charges for the possession of up to 2.5 grams of certain illegal drugs for substance use. Bien que prouver cette requête est significative, cette exemption est seulement un outil que notre gouvernement utilise pour réduire la stigmatisation, réduire les risques liés à la consommation de substances et pour sauver des vies. That said, we can and must do more. And again, data is going to be unbelievably important as we go forward. Data on public health, data on public safety. This public health crisis continues to grow and take more lives every day. Every day we look beyond the numbers. We see the beloved daughters, sons, parents, friends, and community members. The memorials that line our streets and the laminated pictures on the bulletin boards of those organizations on the front line of this crisis remember us every day. It compels us every day to do more. To address this crisis effectively, we have to take a comprehensive and compassionate approach that will reduce the stigma, preventing those in need from seeking help. We have to work with Canadians to end the judgment and stereotyping. We need all Canadians to understand the importance of harm reduction. Parce qu'on ne peut pas soigner quelqu'un qui est mort. We cannot help people who are dead. There is no recovery model for people who are dead. I'm committed to working closely with organizations on the front lines of this crisis. All orders of government, stakeholders, and people with lived and living experience of substance use, as well as everyone participating in this summit, to develop culturally safe, trauma-informed, and evidence-based programs that will save lives and reduce the stigma so that people using drugs will be able to build the trusting relationships necessary to be able to access the life-saving supports they need and consider a life on a better path. Although COVID has resulted in more people struggling in mental health and substance use, it seems to also have resulted in us all becoming a little bit more open, a little bit more comfortable about talking about our own mental health, and perhaps a little bit more resilient. And maybe when more people, I believe, are more comfortable talking about mental health, it helps to reduce the stigma that is still that barrier to seeking care. Mais les soins doivent être là quand ils en ont besoin. We must design the wraparound supports from the bottom up, listening to those with lived and living experiences and together with the people who are in their communities who are doing such great work. There is much more to do, and it's up to all of us to do this together. Jane Jacobs said that good public policy is only ever made when the policymakers can see in their mind's eye the people affected. As you gather for the next few days, I am sure that that view will be front and center for the way forward for Canada's health and healthcare systems. J'ai maintenant hâte de répondre à vos questions. J'ai également hâte de voir le plan d'action qui va émerger de ce formidable sommet. Thank you again. Merci, Miigwech. As I said, I really wish I could be with you, but I'm really pleased that Louise was able to forward some of the questions that you have. So I'll read the questions and I'll have a go at the answers. So the first question that you sent was, we know there is a division of responsibilities in health between the federal and provincial governments. How do we ensure alignment between these at the federal level and with the PT government so that we can have a seamless pan-Canadian strategy? That's a great question, especially coming out of the federal provincial territorial meeting that maybe made it look like it's a little bit more clear to the provinces than maybe it is to us. This is a shared responsibility. The health of Canadians is a shared responsibility. And we have a responsibility as the federal government to look after those for whom we have direct responsibility. I believe most people feel that we as the federal government are the fifth biggest healthcare system. If you add together First Nations, Inuit, and Métis, the armed forces, the veterans, RCMP, corrections, this is a really important responsibility that we take very seriously in that whole of government approach, including our public servants. And so how do we make sure that the population that we have direct responsibility for have better health outcomes themselves? And that means that we have to be listening to the patients, listen to the people who serve in the federal government in many ways, but also in terms of, as you focused in this conference on First Nations, Inuit, and Métis. And we have to learn that responsibility needs to also be about listening and bottom up. At the moment, as we design the transfer and for my responsibility in the mental health transfer, I think that is an example of how we can do this better, how we can ensure that all Canadians know and have access in terms of transparency and accountability to the data. And that's where I think that we are going to move forward with the mental health transfer, that we can be able to craft the transfer perhaps more like the child care agreements, where there is an expectation of receiving the data back such that all Canadians can see what's working, what's not working, how do we identify the wise and promising practices across the country. And as I said in my remarks, I think the integrated youth strategy is one of the really exciting things where we, as the federal government, will be able to fund that strategy that will make sure that young people will get the most appropriate care in the most appropriate place by the most appropriate provider at the most appropriate time, in the way that wraparound services of a step care model, peer support, family doctors, the social workers, the idea of addiction medicine, housing, education, employment assistance, that kind of integrated care that is the Foundry in British Columbia, it's Hub Model here in Ontario, it's Access Open Minds in Quebec, and now everybody understands that kind of putting the patient at the center of the care, which I know all of us have been saying for a very long time. If we can actually create a model that will work in actual patient-centered care, run by young people and with their advice, that this can really change in terms of the true transformation that all of you are here at this conference working for. So there's no question that the federal government is providing the transfers to the provinces and territories. The healthcare is delivered to the bulk of the population by provinces and territories, but I think as we learn through COVID that patients and citizens want to be able to see a system that is transparent and accountable for the results. So the second question was, what are the roles of patients, patient organizations, and community health services in helping to ensure the optimum delivery of mental health services? Well, I think it was really interesting a couple of weeks ago at the Global Mental Health Summit in Europe that at the oldest hospital in Europe, in Rome, that they were beginning as advocates for mental health services to talk about nothing about us without us. I had to remind them that as a colonized country, that we've been hopefully trying to do better, walking the talk of nothing about us without us, with First Nations, Inuit, Métis, with the women's movement, with the gay rights movement, with persons with disabilities, and now with those with lived and living experience with mental health. Nothing about us without us is going to be the most important way of getting this right. Whether it's research, what are the questions that people want answered, or right to the frontline services? Is it where it needs to be when it needs to be there? And particularly as we know the role of virtual care now and the fight for some of the issues around national licensure. It's been the patients and the patient organizations, and sometimes some of the professional organizations like Indigenous physicians, but certainly family doctors that are fighting for the idea that young people should be able to get their mental health services even if they go away to university, be able to keep their counselor, keep the supports that they had in place before they moved away. That francophone patients should be able to receive mental health services in their own language. That there is a real interest in obviously the Indigenous way of knowing and being part of the care for Indigenous patients across Turtle Island, and to be able to get that help from somebody who understands. And one of the other examples they're saying is, of course, even in post-surgical care, that the person who did the surgery should be able to follow you up regardless of where you live. And so I think that just is an example of how patients our voices are very much part of the push for national licensure and the push for the kind of virtual care that everybody was asking for before COVID, but then miraculously appeared during COVID, and now nobody wants to roll any of this back. So I think that we need to find different ways of ensuring that patients' voices aren't just token on a board, but are real, and that there is a a consensus view. That means that now we have a advisory committee at Health Canada on those with lived and living experience of people using substances, that those kinds of very serious voices that are, yesterday at the CIPSERT, the research on patients or people on the front lines of public safety, that committee that they've formed to determine the research questions, determine the kind of services that people, that firefighters and police officers and the RCMP actually, that the questions being asked and answered, but also the program delivery is what those patients and people need, and I don't think we can do it any other way. This is the patient saying what they need and what they don't need, and need to be listened to, but in a much more formal way than has been done in the past, and that's why we're going to need your help and seriously look forward to the summary of this conference. So your third question was, we have a shortage of medical staff in many areas, and this is starkly true in mental health and addictions. What is the federal government planning to do to help improve this situation? Well, I think that Minister Duclos has, and together we're putting together this coalition of providers to be able to figure out how we work better together. And I think a lot of people feel that the numbers of providers is not adequate, but the maldistribution of them has been acknowledged for decades. And so it is interesting as we move on what in mental health is now viewed as an example for lots of health in terms of a stepped care model, from peer to family doctors to more mental health supports for those family doctors, the social worker, psychologist, the psychiatrists, and specialized psychiatry programs. That it's really interesting to see, say, the Dr. Vigod's study that of the 40 patients in the intake of and perinatal mental health, that only 2 of them needed the very specialized perinatal psychiatrist, that everyone else was helped in a different level of care. And I think that these kinds of models of stepped care are exactly what we're talking about. The most appropriate care in the most appropriate place by the most appropriate provider at the most appropriate time. And that place includes virtual. And so how do we know that, the addictions medicine docs at St. Paul's in Vancouver are very interested in being able to help family docs across the country find that right molecule, find the right recipe to help this person struggling with substance use. As I said in my remarks earlier, in this big, huge country where we're not going to always have the right provider in loco, it's going to be really important that we step up the approaches to the kind of care virtually. I think it's really interesting to hear that the farmers want to be able to talk to somebody who understands farming, that you end up with what we continue to talk about, culturally safe. How do people access something culturally safe, the kind of care? The Black Therapists network in Edmonton was truly impressive as to how that creates a shortcut for the Black patients to know that somebody understands and lives systemic racism, and that doesn't have to be explained to their counselor or their therapist. So when we put in place the Wellness Together platform. We now know that we are going to have to fine tune it so people can get more quickly to the kind of supports, whether that's the 2S LGBTQIA+, whether it's the cultural diversity, whether it's frontline health providers, that we can get a customized approach to that virtual care. And now, as we are building to the 988 number for suicide and mental health situations, as was launched this summer in the States, that we're trying to build out that kind of care so that there really will be a suicide action plan that means that there's a place to call, someone to respond, and somewhere to take them. And so that will be part of an action plan, but it means that we have to have the capacity to make sure those calls are answered, and that they are answered by the best possible person who's well trained and knows can get people the help they need where they live. So this is, I think, a very exciting next step. But again, it's how we're all working together with the provinces and territories to make sure that that system will work, but also to make sure that people in community understand that it's there for them, but we still have to have capacity in community as well. So I think that it's going to be a combination. We also, I think, have to get we have to better deal with the burnout of the people who are already in these positions. We are hearing from nurses that we're doing as an RPN or an RNA, that there wasn't a bridging program so she could become a nurse or a nurse practitioner that might have an interest in mental health and addictions or whatever, that they've decided to leave the profession altogether and go and do something else. So in the focus on recruitment, retention, all of these things, that the principle of putting patients at the center of that, and getting people, even young people, experience with how satisfying it is to work in mental health, to work in a substance use clinics, that this is really one of the most important ways of improving quality of life and saving lives. So I think we've got to get rid of some of the stereotypes and misunderstandings of how satisfying this work can be. But we also need people to choose to work in health and healthcare and public health at a time when really people are hearing about how tough it is and the burnout of the people in those professions. And so I was really pleased to hear that some of the volunteers in the distress centers, that when you talk to those volunteers, that they actually are thinking about maybe going and becoming a social worker or becoming those. And I hope that we'll see that in the First Nations, Inuit, and Métis communities as well. That when I first started becoming involved in the Indigenous rights, it was really interesting that the young people all wanted to be lawyers so they could work on land claims. Now we need them to think that a career, as we have the head of the Canadian Bar Association, the head of the Canadian Medical Association, are Indigenous, that there is a real career for not only First Nations, Inuit, Métis, but looking to all Canadians in our diversity, thinking that a career in healthcare, mental health, addictions is something where they could make a real difference.
So I'll just start us off by thanking Minister Bennett tremendously for the time that she took to provide those remarks and her support of the work of the summit and interest in hearing more about the work that we do from here. So I also just want to thank the people who are actively chatting. This is a huge topic. I really appreciate like the challenging of stigma right in the chat already. And we're actually going to spend some time having the opportunity to discuss with you some of what Minister Bennett talked about, because she touched on so many things. So Louise, I'll turn it over to you to start us off with some reflections on some of the key points she made.
Thank you. So just quickly, so that we can get to the real experts who are the ones in the audience, I'll just say a few things that I noted. I have to say that I was so impressed that she understands the value of a national data management strategy. And is clearly supportive of that, and that it should be shared and transparent and accountable. And she certainly, I want to encourage all of us to become really engaged in this issue, because without these data strategies that are shared and linked and aligned, we are not going to even know the questions to ask and the evidence that we have and don't have in order to be able for solutions. And I've really been calling for all of us to consider educational webinars, and we're definitely going to look at educational webinars for people, because most people don't know what a data strategy is. They don't understand how it affects them, and so it's easy to kind of glaze over, and heaven knows they've got so many other things on their mind. So we're going to have to start with education, I think. But I was delighted to see that, and I really appreciated her endorsement of the summit's declaration of patient data rights. And I hope we can continue to get sign-ons for that, because what it really does, that document, is say, it's okay, patients. These people will protect your data, and where appropriate, they will anonymize and use it. We want our data used for research. Almost all of us do, but we want to be protected, of course. So that was wonderful. I also noted her support for continuing virtual care. And I couldn't agree more. We're going to have to rely on all these resources. But what I also appreciated was that she made a mention of customizing it, because, we brought it in at a time when we had a very, like, an emergency. So in an emergency, you don't analyze things, you just do the best you can. Now it's time, I think, for us to look at where it really does work and where it really doesn't. And there are places where you actually really do have to see someone, the whole person, in order to be able to deal with it. So I was pleased to see that. And of course, nobody will be surprised to hear that I love that she's talking about patients being the best teacher, and they should be at the center, and not just the center of other people acting on them, but they should be and she mentioned this, they should be more formally engaged in the decision making and evidence making processes. So that was wonderful. I do want to give her a shout out for the courage of the federal government in supporting the BC exemption from the Controlled Substances Act, and I'm very hopeful that there will be more of that. That there will be more of that. So, and of course, I mean, it goes without saying, but I'll say it anyhow, that, it's clear that she understands the two I's of Indigenous and non-Indigenous ways of learning. And that's wonderful. And I think that we are starting to understand that much better as well. So, so those were sort of some of the big highlights that I picked up from her presentation. And of course, I also would like to thank her for her kind remarks about me. And we have worked together, Carolyn and I, since way back, trying to save the hospitals in Toronto that she was involved in, and I was. And I really, she's a very hardworking person, and I think is very sincere in her support for all of this work. So I know she had answered a couple of questions for us that we sent to her later that Antonella, you'll go through, I think. And then we should open it up and get everybody talking as they already are. So, and thank you all for your, interest and coming to this summit. I know how tough times are now for people and how many ways people are being pulled in a million directions, including myself. But it's just wonderful that we can still continue to find solutions and be optimistic and courageous and compassionate as we move through such a difficult time. So those are all my remarks. And so I'll turn it over to Antonella now.
Thanks so much, Louise, for getting us started. So just to follow up on Louise's perspectives that she shared, we thought because Minister Bennett touched on so many huge topics that are important to all of our communities, and particularly now with the pandemic, it would be a great opportunity to open it up for discussion and reflection before we go on to our next session. So there are already some great comments in the chat, but really, I think the fact that Minister Bennett talked about recent surveys that found that over 50% of people indicated that their mental health has worsened as a result of the pandemic. In the Angus Reid poll that I think she's referring to, they also talked about 44% of people said that they had feelings of depression that increased. 41% said feelings of anxiety. And we know, again, from research that certain groups have been disproportionately impacted, including people from the communities that we're going to be talking about today. And parents and other individuals who are disproportionately affected by challenges and barriers in the healthcare system. So we really want to open this up for discussion. There are some great comments, but before we do, like Louise mentioned, I wanted to read the responses that we got from Minister Bennett on a couple of other questions that we asked her that we'd heard from the community. So I'll read these out and then turn it over to see if anyone has any follow-up comments to what we've been hearing today so far. So we asked the question, what are the most pressing issues for Minister Bennett regarding children and youth mental health? And what is the federal government's strategy for addressing these issues? And her response was, as we all know, the mental health of young people has been significantly impacted by the pandemic, with the separation from friends and family and the impact of lockdowns on everything from job security to school. So many young people reported an increase in stress, worry, sadness, and loneliness. However, we've also seen more young people coming forward to share their experiences and seek help. Looking to the future, it's essential that we keep up efforts to ensure children and young people know that they're not alone and that it's okay not to feel okay. With leadership from the CIHR Institute of Neurosciences, Mental Health and Addiction, our government created the COVID-19 and Mental Health Initiative to identify knowledge gaps related to COVID-19 and mental health. Over the past 2 years, this initiative has mobilized evidence on the impact of the pandemic on the mental health of children and youth. And more recently, CIHR and the Graham Beck Foundation came together to launch the Integrated Youth Services Networks Initiative, or IYS. Which funds research to help create cohesive systems for delivering mental health and substance use services for youth across Canada. Health Canada is also funding the Improving Integrated Care for Youth initiative, a nationwide initiative that builds health standards and implementation tools aimed at improving the integration of youth and mental health and addiction services. We'll continue doing whatever it takes to ensure that children and youth receive the most appropriate care from the most appropriate provider at the most appropriate time. So we thought it would be important just to share those perspectives and answers from Minister Bennett, because it may be news to some people what's happening federally. And I'll just quickly review the second question that was posed to her and then turn it over for discussion. We asked, how do you see the intersection of mental health and addictions and social factors that impact health, including housing and economic security? So she touched a little bit on this, but elaborated in written remarks with the following. Even before the pandemic, it was clear that mental health and social determinants of health go hand in hand, with mental health and addictions challenges being tightly linked to social inequality, which is economic insecurity and housing insecurity. This relationship is also cyclical. When someone doesn't have a safe home or enough money to put food on the table, their stress is heightened, leading to poor sleep and diet. This level of constant worry can lead to or exacerbate mental illness. On the other hand, people with poor mental health are more vulnerable to poverty and homelessness. And for families, this can also lead to violent family conflict. This is why it's so important for our government to bridge existing gaps in the healthcare system, including through targeted funding to support projects that promote mental health and prevent mental illness in vulnerable populations like youth and racialized Canadians, which were disproportionately impacted by the COVID-19 pandemic. We've also made investments to support all survivors of family and gender-based violence and make it easier for people at risk to access the culturally relevant and effective mental health services they need. It's also why we're committed to developing national standards on mental health and addictions so that Canadians will know what they should be able to expect in evidence-based care wherever they live, coast to coast to coast. We want all Canadians to know if they need help, they are not alone, and that there is support available to them. So again, based on those responses, that's what she graciously provided in written follow-up to her address, we wanted to open it up to conversation. We had some perspectives already shared in the chat, which were amazing. And one that stood out to me was, whether all of them did, but one that I thought was interesting is, to get us going maybe, is the point that that the governments need to understand that mental illnesses are not just with individuals who may be homeless or struggling with addiction. There are many traumas which make life a bigger struggle, and they may need help mentally. And this struck me because we're all serving communities who live with different disease and disabilities and experience different challenges related to social determinants of health. And one question that occurred to us is to pose to you all is, what have you been doing or seeing lately that in response to the mental health needs of your community as a result of the pandemic, to support people with this exacerbated distress that they might be experiencing at this point, 3 years into the pandemic? Does anyone want to share or reflect on that to get us started on a little bit of a conversation on what we've heard so far?
It's Sharon here. I have a comment. In Saskatchewan, I found something very interesting. There's a fellow who is talking about men's mental health, and he's been very well received by Indigenous and non-Indigenous men, because I think a lot of times we neglect men, and we don't really acknowledge that often they have traumas in their youth too, and whether they've been abused, or whether they've come through wars, or whether they're refugees or whatever, they all have these traumas, and as men often we don't give them time we don't acknowledge it nor give them the support they need.
Important. Thanks, Sharon. And if you do want to eventually pop that resource into the chat, just if people want to check it out, if they're in the province or otherwise, it's a really, really important point that we look at these subpopulations and unique needs and challenges that they might have when it comes to mental health. I see a hand up, and I invite you, Vikram Babur, to please unmute yourself and share.
Well, thank you, Camille. I think as you excuse me, as you pointed out in the chat, that again, that my comment about it seems to be that although governments have heard, and when they talk about this mental health and everything else, they're always lump it with the addiction, homelessness. It's like there's something wrong with these people, right? And we have to really, there's a lot of stigma that needs to be overcome. And stigma, yes, hopefully changes with time, but hopefully, I think we really need to move forward in how we address, or how we even say mental health, or, because even though, like, mental health is not something you can physically see, right? Whereas any other health, physical health, you generally can see whatever the issue is, and that's why it's easy to figure out what you need to do with it, right? Whereas mental health and brain, the brain is very complex. And I hopefully, going forward, we can really create a national standard and it's great that the ministers had a meeting here in Vancouver, but from what I understood, they weren't able to agree on anything, really. I don't think that anything came out of it, right? Even though they spent a lot of money to come out here to Vancouver and a lot of money was spent to get them here. But I just, after I've been along with the system, the health system for so long, and I find that I haven't seen anything really improve and move forward. It seems we have a lot of talk about these things, but we never actually do any. There's no action to follow up with all the talk that we had.
Thanks so much. And I hear you. And I think all of us can really hear that last sentiment. And it feels that way. But I do want to pick up on just a couple of things that you said. Challenging stigma, that's a huge point. And I think, we had a great example in the chat where we all have a role to play in learning about and challenging stigma and understanding these issues, and using every opportunity we can to do some of that education and sharing. So even though it may not feel like we're making monumentous change, or we are each in our own work able to kind of move the needle as much as we can. So even in just sharing, ways, different perspectives on how we look at some stigmatizing assumptions is really important. And the other thing I just wanted to pick up on before I turn to the next person is your point about the federal government coming together with the provinces and territories, and just reminding people, we've been encouraging as where we can, federal and provincial and territorial governments to look at that data sharing opportunity, and to because Minister Bennett did say in her remarks, and it's really important, we have to understand, and we say this all the time, of course, what the needs of patients are, and we need the data and the data strategy and maintenance strategy to be able to share that information across the country, and also make it a transparent and accessible process. So again, everywhere that we can push the needle, we try. So I just want to turn it over to another person here, Carrie McIntosh, if you'd like to unmute.
Hi, everyone. My name is Carrie. I work in sort of northern Manitoba, I guess, on a First Nations community. And I just wanted to say that what we're seeing now, trying to come out of the pandemic or trying to engage people back into community, is a very high level of family stress due to inflation and food insecurity, also interpersonal relationships, and children not always returning back to school, even though the schools are open and the teachers and administration want the children there. There's still a large fear, I don't know if that's the right way to say it, a big fear of people getting sick by going to school and then bringing that back to the house. And that also leads to like too many people living in one house, and there's not enough housing available on the First Nations for families to be able to sleep properly, to be able to have their own space, to have safety and security while they're sleeping at night. So all of these things, I think, are like, it almost brings it back to community or familial level. And it's really tough to make a difference that way, like from the front line. But we're trying to, provide food for families, provide referrals or access to different whatever mental health services are available. So it kind of scales it back from the pan-Canadian approach, but just at the community level, that's what we're seeing. Thank you.
Thank you, Carrie. That's such a great point and perspective from the front line. And it is kind of interesting how, when you think about trauma, and whether it's this grand scale trauma that we're referring to with the pandemic, or our individual needs, it ultimately does come down to those basics, and those, ensuring those basics are met and seen through. So really great points about those needs and how you're working to address them on the community level. I'm just checking here to see if there's any other input from our chat. Leah, do you have any
I
remarks you
actually
want
want
to
to
share?
flag a couple, yeah, because it picks up
Sure.
on some of what Carrie was just sharing, and actually I think one of the comments might have been hers in the chat, and it's just there was a couple of points here. One, and just bringing this back to in the community and the wisdom and that's already there. I mean, there's a lot about, and we completely agree with nothing about us without us, bottom up, but there needs to be the capacity in the community to do that bottom up work and to address you know, and be nimble and be able to address what's being seen at that level. And so a couple of the comments here, you know, part of reducing the stigma is not assuming everyone who uses substances needs or wants help to quit. Bringing in access to SCS and drug testing facilities are desperately needed. And a comment, I think it was from Carrie too, just, you know, how about funding charitable, volunteer and health organizations that are already doing the work in community on the front lines? Communities already have the answers and but not the resources. For example, we have one child and adolescent counselor at the Provincial Health Authority for population area of 8,000, unbelievably dangerous for youth who are struggling with mental health issues. And so, yes, it's, you know, I think it's just important to flag these pieces and, you know, that ability to have better data and understand what's happening at the level of outcomes, I think is really huge to be able to give a lot more flexibility to how communities and community services are funded to do this work as well. So above and beyond more resourcing, even within the existing resourcing, giving that flexibility to use those dollars in the way and the people and the time in the way that are needed to achieve, you know, outcomes that matter most for the communities being served, so that it's not necessarily, you know, if you were funded to do one particular type of project and then, you know, you're being held accountable for you know, delivering on a certain number of whatever the case may be, a particular product that you were funded for, but you are determining that actually you need to flex as you go through this, and what you thought might not be correct, and you actually really want to use those resources in a very different way to achieve a set of outcomes. That ability to be that flexible and not to be held accountable for the individual products that you said, you know, at the beginning of your grant cycle you were going to deliver. It should be about, okay, we said we were going to try to achieve these outcomes, we're able to achieve these outcomes, and the way we did it was whatever ended up working, right? So there's that whole piece around understanding what the outcomes are you're trying to achieve and holding people accountable for those as opposed to activities and outputs and all that. And then I just, as someone who's based in Ontario, to give the example of just how are we resourcing the system and where do those, at what level do they go? You know, when there was an increase for mental health funding provided by the federal government to the provinces and territories over the last couple of years in Ontario, it didn't, as far as I can tell, it did not go towards frontline services or to people doing the work in communities. It seemed to go to a new level of sort of system level bureaucratic approach to using those dollars. And do we really need more people, you know, holding accountable, or do we really need to address the shortages and the gaps and the long wait lists in community at the level of care, and give those community providers the flexibility they need to achieve the outcomes that matter most for the people they're working with? So that's my little 2 cents to add into that reflection as well.
Thanks, Leah. And just flagging too that someone, Corey Ferguson, put into the chat a current campaign that the CMHA National is launching, along with many national partner organizations, to, I guess, hold the federal government to account for the Canada Mental Health Transfer funds that they promise. And again, to your point, Leah, it's really seeing through how those funds are used and how they're appropriate for the community to best use the dollars that are there to support the people that they're serving. So it actually is a really interesting maybe segue to another question that we were thinking about, you know, there's a lot of talk about ensuring putting patients at the center, and actually engaging patients as meaningful, like just partners in decision making from every level of healthcare. And part of it is kind of what you're describing, Leah, is ensuring that communities have the flexibility to be able to serve their communities in the way that's needed. So I guess posing a question out to others, like any perspectives or anything that resonated with you in terms of how do we ensure that the patient perspectives are engaged at those decision making levels, and any perspectives that you want to share on that whole thing about, you know, putting the patient first. And there's a lot of talk about it, but anyone want to share their perspectives on that when it comes to serving our communities and their mental health in particular?
Anything that you find is really working with your community, or any real barriers that you're facing that you really want to flag, and solutions you'd like to see put into place? Not seeing anything come in.
I saw a hand. Is there anything else that you think would be important to bring up? I mean, that's just a question that is a point of reflection, but anything else anybody wants to share about what we've heard so far, about what they're seeing right now when it comes to providing support to their community and the mental health challenges that you're seeing right now, or opportunities that you're seeing?
Pat, you mentioned youth wellness hubs as a network of hubs across Ontario. I'd heard a little bit about them when they were coming into formation, but I think they've been in place now for a little bit of time. I know there was a little bit of controversy I was hearing about when they were coming into formation, but if there's any reflections from anyone who's based in Ontario, Pat, or others who are familiar with these youth wellness hubs, are these good examples? Minister Bennett talked about, obviously, the importance of person-centered integrated care models. She talked a bit about stepped care and other approaches like that. And she referenced the hubs here in Ontario. So anyone have experience with these and have any commentary? What's working with them, or what isn't? What could improve?
Hi, thanks, Leah. It's Pat.
Hi, Pat.
Yeah, well, I've moved up to Owen Sound in the last recently, and I'm actually working with the Pulmonary Hypertension Association of Canada on issues around access and treatment and research capacity building. But in my volunteer time, I'm interested because Owen Sound actually has some really concerningly high rates of access to housing, mental health, addictions. And we also have, sadly, a municipal government that hasn't embraced its role in understanding this, or taking an understanding of housing first, for example. And so it's been an uphill battle, but those of us involved, I think, in social justice and advocacy certainly see, the opportunity to raise awareness and public education as a key start to that, and certainly addressing stigma. But in speaking with just local officials involved in United Way and elsewhere, one of our biggest challenges here is the youth and the exodus of young people from our community, because there isn't a lot other than hockey, which has its own problems. We don't have a lot. We haven't really focused on some of those challenges. And I approached actually the youth wellness hubs and found them to be extraordinarily easy to deal with, welcoming, quick in their response, very much approaching what are the kids in your community saying? What are they involved in now? What would they want? Where would they want it? Do they want it virtual? Because we serve a really big community here in Grey Bruce, and we are actually the only counties that don't have a youth wellness hub. So, we have the pipeline of kids either exiting or dealing with some of the big challenges around mental health, addictions, drug use, We also have one of the highest use of alcohol and alcohol admissions to ER. So it seems to me, people who, and I have kids and grandkids, so this really concerns me in a small community. So I approached them, and I've just found them to be remarkable. And right away they knew, that the place to start is with our local kids. So I have nothing but a good experience with them, and I know that they've expanded across the country. So I think if you're looking at how do we destigmatize, so these are, for those who don't know, the Wellness Hub model offers kids, you can get after school help, you can get help learning to make sushi, you can get help with homework, you can get help with mental health, addiction, because that's the way kids think about their problems. It's a holistic approach. I got problems at home, I got problems with school, I've got problems with my girlfriend, whatever the issues are, the approach is we're here to help you find the resources you need at the time you need them in the way you want them delivered. So I would just encourage anyone who's interested to take a look.
Thank you, Pat. That's really heartening to hear. And thank you for touching on some of the dynamics and the realities happening within Owen Sound. For those of you from other parts of the country, Owen Sound is sort of a small to mid-sized municipality. I'd say maybe more mid-sized in Ontario, sort of in between, not quite southwestern Ontario. It's making your way north, and it's right at the base of Georgian Bay, where the point goes in between Georgian Bay and Lake Huron, and that dynamic of out-migration of young people leaving more rural or smaller municipalities is one I've heard about for a really long time, and I've often heard about it in the context of numerous things, including poor determinants of health and needing to leave. Or sometimes keeping those determinants of health really hidden so as to not have to leave the social networks. But for example, homelessness being a couch surfing phenomenon, not necessarily something you would see on the street. And so really talking about that and talking about the dynamics in terms of substance use and mental health there. And the fact that there was no hub available in your jurisdiction, but that you were able to reach out to one who's incredibly responsive and nimble and willing and able to start from the point of view of the young people in Owen Sound. So that is really incredibly heartening, and good to know that they are becoming, they are starting to spread. Not I'm not supposed to use the word spread anymore. They're starting to move and become available across different jurisdictions outside of Ontario as well. So if anyone has any further, thoughts and experiences about these hubs.
Yeah, it's a very hopeful model as well, because when you see some of the comments coming in here, and like Corey just points out, it's often related to funding structures, unfortunately, in terms of being able to actually have those services provided in a community. But the model itself is hopeful, and because we are seeing a lot of chat in the box there, or information in the chat box about people just not getting a closed door when they go to try to reach out for help, and having to kind of fit the mold. Like, you can't be patient-centered if there's a mold for you to fit in, right? These are not patient-centered when you're being rejected from programs. So the hub model does create some hope. And I mean, it's interesting, we're talking about mental health and addictions here, but I see the same in, services for psoriasis and psoriatic arthritis, and how people are constantly cycling through trying to get the help that they need because they're not kind of fitting that expectation or not in the right place to get the services that they need. So really interesting. And I also just wanted to point out that our first panel for today is really going to talk about some of what they see as opportunities moving forward that are relevant to their particular communities, including from the lens of mental health and addictions. But I think we can all really learn from each other in terms of how the opportunities and barriers our communities are seeing. So we'll hear more about some of these topics that came up in terms of some of the challenges and how we can work through them in our panel today. So I do want to recognize the time, which is why I'm moving us forward to our panel. And please do keep popping information into the chat. We really appreciate the opportunity to think through some of what we've heard so far. But we are so excited to turn it over to our next speaker. I'll turn it over to Sharon, who will introduce our next keynote. And then I look forward to being back with you all for our panel shortly.
Okay, great discussion there. And I know people are going to be holding that for later on as they add in. So it's my honor to introduce the next keynote speaker. Richard Jock, just so you know, has been at the forefront of strengthening healthcare to better serve Indigenous peoples. But you know, by impact, it improves the health system overall for all folks. So Richard Jock is a member of the Mohawks of Akwesasne and serves as the Chief Executive Officer of the First Nations and First Nations Health Authority. Richard's portfolio includes health benefits, policy, planning, engagement, service improvements and integration, investment strategies, and regional partnership implementation. So his position also provides leadership for the building, functioning, and implementation of strong partnerships within the First Nations health governance structure and within the health system more broadly. So Richard has worked for the past 25 years for First Nation organizations and the federal government, including numerous positions in the health field. Immediately prior to joining the First Nations Health Authority, he held the post of Chief Executive Officer for the Assembly of First Nations. Among his other professional roles, Richard has held senior leadership positions at Norway House Health Services Incorporated, Health Canada, and the National Aboriginal Health Organization and Mohawk Council of Akwesasne. And Richard is a great advocate for health and wellness and challenges himself to stay active and spend time outdoors. He wears his Fitbit daily and rarely misses 10,000 steps. So, and enjoys playing racquetball in his spare time when he has spare time. So with that, I would like to invite Richard Jock to share his insights and vision for the future of healthcare. Richard? Yes, please.
Yes, we can see the slides. Thank you.
Hello there. Sorry to interrupt. I think some of us can't hear your presentation. I saw someone else writing in the message, so maybe there's a tech issue that needs to be resolved.
I'm able to hear Richard. If some people are unable to hear Richard, try going to the translation world icon and select English and see if that resolves your problem.
We're also flagging this to our tech support because there's a handful of people, but if this works for you, please let us know in the chat that it's resolved by what Leah's just suggested.
Richard, I think it's okay for you to proceed, and then we'll, sorry about that. Yes, advancing the slides.
And that this has really required us to have a nimble public health response, but also to pivot some of our primary care and related service areas that they resided in, so that we were able to do environment in BC, that it's really
Okay, excellent. Thank you, Richard. You've given us lots of thoughts and lots of ideas for moving forward. And I'll just mention a couple of them, and then we can probably our time will be up. Okay, so you talked about the importance of community-based and engaging. I like the idea of the biannual sessions to engage with communities. I think often health authorities are missing that piece. Virtual doctor of the day to enhance access. We thought that was good, and access to care. Virtual psychiatry service. Also evidence-based and timely analysis to enable to support design and service delivery. And also that this issue about the toxic drug crisis is becoming a community-based issue, which I think in many provinces we're starting to see that. I also like the idea of ensuring that there's some way to track client satisfaction in the services provided. And the importance of partnership with communities in the design, collaboration with them in the services provided. That was excellent. And how to put data to work for the communities. I think that's a thought that other health systems don't really think about. They get the data for themselves and not really to feed back to communities. Reporting up to the funding sources and those people, as well as to communities, and how data can affect operations. Thought that was a great observation. And also the network of healing services. I mean, there's so much, so I won't go into all those details. I'm sure that everybody captured notes for discussion later. So I did want to thank you so much for attending, and we hope you will be able to participate in our upcoming discussions, and also for the day 3 and day 4 and day 2 and day 3 that are coming up, if you can. So on behalf of all of us, thank you very much. Okay, over to you, Leah, I think.
Actually, Antonella, there she is.
Antonella.
Thank you,
Thanks,
Sharon. Thank
Sharon.
you, Richard. That was fantastic. And apologies for some of that translation interpretation back and forth. Hopefully it's all resolved now. That was wonderful and incredibly informative. Thank you.
Thank you. I always feel like we have such amazing speakers, and now we're going to move on to even more interesting and thought-provoking conversation. So already so appreciative of what we've heard so far. But I do just want to say thank you to everyone for your patience with the tech issues and the challenges with the toggling from English to French. I think there's a reset that's just happened, so I'm hoping that we'll have less interruption during the rest of our day. Oh, and no, we won't. It seems I just got interrupted by the interpreter. So please, thank you for your patience. We'll try to figure this out for the next day's session if we can't for this afternoon. But I invite our panelists, our first panel for this year's summit, to please begin sharing your screen. And if Zoe Dodd, who's our first speaker today, wants to get started on sharing her slides while I introduce the panel, that would be amazing. So today's panel, I'm just going to refer to my notes so that I make sure that I introduce you all very briefly. Today's panel is called Echo Pandemics and Paving the Way Forward, and it includes experts providing various perspectives on how we address the pressing health and social policy issues from the lens of specific populations in the patient community. So as we have already, there's going to be a moderated Q&A at the end for all of our panelists. So please do continue to pop your questions and thoughts into the chat. This has been amazing learning in the chat itself. And I'm going to do a quick intro to our panelists, but their full bios can be found on our summit website. So Zoe Dodd is currently the inaugural community scholar at MAP Center for Urban Health Solutions at St. Michael's Hospital, Unity Health, and co-organizer with the Toronto Overdose Prevention Society. Dr. Sandy Sadev is currently a medical oncologist at the Ottawa Hospital Cancer Center. Rachel Mannion is coming to us as the executive director of the Canadian Skin Patient Alliance, a national nonprofit organization that supports people affected by skin, hair, and nail conditions. And Laura Tamblin-Watts is the executive director of CanAge, Canada's National Seniors Advocacy Organization. I really thank you all for being here. I can't wait to hear your presentation and for the discussion that follows. And Zoe, I'll turn it over to you to get us started. If you need any help with the slides, just let us know and we can do that for you.
I actually don't have any slides today. I thought about making slides. I decided not to. So first of all, I just wanted to thank you for the opportunity to speak today. And I first want to acknowledge that I'm speaking from the territories of the Mississauga of the Credit, the Anishinaabe, Haudenosaunee, Wendat, and Petun, and that this is home to many First Nations, Métis, and Inuit. I also want to acknowledge how the toxic drug death crisis has disproportionately impacted Indigenous people. And so, yeah, my name is Zoe Dodd. I work as a community scholar at MAP Center for Urban Health Solutions. I also been working in the downtown east of Toronto for almost 20 years, doing harm reduction, supporting people who use drugs, working in around issues related to homelessness, poverty, HIV, and hepatitis C, and how these issues all intersect. I worked 14 years at a community health center, which I'm just currently on a secondment from. And I'm here to talk about overdose and the toxic drug death crisis that we are currently living in. So our latest data suggests that 21 people are dying a day. And during the first 2 years of the pandemic, the numbers of people dying increased to 90% all across the country. And this has been felt all over. There are numerous factors that contributed to this increase, and including the increasing toxic drug supply, isolation, services being lost, closed, grief and loss, lack of service, government interference, political ideology, which continues to hinder responses. Provinces such as like governments in Alberta, which have been hostile, closed one of the largest safe injection sites in North America, one of the busiest actually, which was in Lethbridge, Alberta. And also, I think about Saskatchewan, which is some of the highest rates of HIV, and in Saskatoon, they're running a safe consumption site there without government funding. So what does it mean for patients in an escalating crisis? And this is something I think about a lot, is that first thing, people who use drugs, who seek help, often feel discrimination, lack of understanding, and mistreatment. Now, if you also add that a person is, Indigenous or Black, a woman, someone from the LGBTQ community, then things also could grow even harder. And then if they're also homeless, it's just people are really mistreated within our healthcare system. And there isn't much being done, I would say, to address that. Sometimes I think if I treated people at my workplace the way people get treated when they go to a hospital, I would be fired from my job. Unfortunately, discriminating against someone who uses drugs is so commonplace. So there's a lack of patient engagement, especially if you're a person who is struggling with substances. Just being able to identify for yourself what those problems are, is a real challenge that always someone else seems to know better than you. So if we look at the minister's title who spoke today, this really also speaks to this kind of idea of for us to understand the crisis, we have to understand the problems. We have to understand what the interventions are. We also have to understand the problems. And her title being Minister of Addictions and Mental Health, we make a concerted effort to call it mental health and not mental illness. We're not in an addiction crisis. There are many people who are dying who would not be labeled with addiction or substance use disorder. It is a toxic drug death crisis. It's not happening anywhere else in the world except for Canada and the US. Our illicit market is being flooded with synthetic drugs, which is fentanyl and drugs that are mixed with them, which has completely taken over the opiate market. You cannot find anything else on the streets of Toronto if you're looking for opiates except for fentanyl. And we could see this coming. So 2010 was when deprescribing started, and patients started being dumped from their doctors. People with chronic pain were being cut off their medications. And people were, you know, doctors were retiring and people wouldn't pick up these patients and then give them like pain medication. And we said then, and also like if people were misusing opiates and getting Oxycontin, at least they knew what they were getting. And no one could imagine at this time that so many people would die. And in 2016, we were calling it an emergency here in Ontario, and 856 people had died. And here we are in 2022, and last year, over 2,500 people died from opiate-related deaths. That doesn't even include stimulants, and over 5,000 people died in Ontario during the first 2 years of the pandemic, which is half the amount of people that died of COVID. So healthcare utilization amongst people who use drugs. So we have a lot of data actually around who's using, where they're using, how they're dying. And healthcare utilization among people who use drugs was higher prior to people dying. 1 in 2 people who died in Ontario had access to healthcare 30 days prior to their death. 1 in 4 had a healthcare encounter 7 days prior to their death. So what does this data actually tell us? So we're collecting a lot of this data that is not actually being used to inform strategies for intervention to prevent deaths. You know, 1 in 4 had a history with chronic pain, 89% had a mental health care encounter in their lifetime, 1 in 6 people were homeless when they died. So these are all the kinds of, there's so many reasons if people are accessing health care and it's actually not appropriate, or they're being discriminated against, or they're not getting what they need, they're going to leave. People being isolated, being homeless is like particularly challenging. And when people start to blame your substance use for your homelessness and not the lack of housing, I mean, we miss those opportunities to really think about what's happening here. So as a system, we need to see people as not separate beings with separate issues, but as whole human beings that are interconnected. The system to support people who use substances struggling is absolutely abysmal. People who use drugs who are struggling are often looking for support and help. And although many people who use drugs do so without major disruption in their lives or negative consequences, there are people who are struggling with their relationship to substances, alcohol, stimulants, tobacco, opioids, etc. In addition to voluntarily seeking help for substance use issues, the criminalization of substance use is also frequently used to mandate people to attend drug treatment programs without their consent and choice. And actually, this is what I did my master's research in, and my interest lies in forced and mandated drug treatment. Seems to be a big call for that to address the overdose crisis, but evidence doesn't support that as a positive intervention. Substance use treatment programs in therapeutic communities, including self-help groups, have long been established, but some of these programs actually lack substantial evidence and little is known about their outcomes. But we keep pouring money into that system, which is actually like a very like a private and public system. And yet we don't see what their outcomes are. They don't have to report like you do in harm reduction. Like we have to report every single thing. We do sometimes four times reporting a year, 3 times reporting. It's just not the same. So drug policy, drug prohibition, the programs created to support people have generally been maintained because of political drive, morals and values, societal norms, and through coercive systems of punishment. You know, seeking substance support for substance use within the current system can be a challenging experience. Long wait times, lack of diversity in programs and models, limited access in rural and remote communities, and costs are just a few barriers. And despite the seemingly availability of treatment programs, many people will seek support through other means, such as their peers, their family, their friends, their co-workers, their chosen family, religious leaders, medicine people, and elders. In fact, the majority of people who struggle with substance use quit on their own, but people can't even get to that place when they're, you know, that we have a toxic drug supply and people die, just like relapsing ones. So the majority of our drug system, treatment system in Canada has adopted an addiction as a disease model approach, which continues to permeate the drug treatment system and the ways in which North American society has come to accept problematic substance use and its solutions in this model. So the drug use is pathologized and attributed to the habitual use of drugs and the moral failings of the individual. And there really is little evidence behind the use of 28 days, despite its dominance in drug treatment system as a whole. So, and the problem is that the majority of residential drug treatment and 12 steps programs have abstinence from all substances and as addiction as a disease. And, you know, this has been kind of this common thinking since 1949, just, you know, with the addition of like dialectical behavior therapy, cognitive behavioral therapy, and so on. And the Canadian Medical Association in 2017 had a study called Realizing the Vision. You know, it estimated that 60% of the factors that make us ill, impact our mental health, and limit recovery can be class social determinants of health. And this is where, like, I really struggle with the way that people talk and see people using drugs. They label people who are, you know, we then silo them within the healthcare system. And there's a lack of understanding of mental health and substance use issues and how they overlap. You know, as a support worker, I've accompanied dozens of people to their appointments. I also have within my own family and friend group. And it's just, people are being historically told, like, you know, seek substance use treatment before seeking help for your mental health, and vice versa, even though the two can be intrinsically linked. So for decades, our system has really pathologized, medicalized, and individualized substance use issues without wanting to truly connect the larger apparatus of how our society is set up to contribute to people's suffering, and creates the need for some people to use substances just to cope with the peril of everyday life. And, you know, we can see this you know, we live in Canada, which, you know, has its ongoing colonial project, colonialism, racism, you know, even our drug prohibition laws were created on our racist drug policies weren't about, you know, the safety of people. And so our whole system is based around this, instead of actually addressing what some of the causes have been to people who are struggling. Problematic substance use is often seen as an individual behavior and a moral failing, not a societal one. It's rarely connected to the intersections of the social determinants of health and their impacts on person's overall well-being. And so widely held mainstream beliefs assume that drug treatment are the cure-all for addressing people's substance use problems. And from my experience working in healthcare system for almost 20 years, it is rare for medical professionals and others working with people who use substances to think critically about what they are referring people to. So for a lot of our health issues, we get referred to like medical expertise, and some places people are referring people where the solution is God. And so that in itself is an issue when we think about not recognizing people's religious or spiritual beliefs and how they also might, what they also might need for themselves. And I say this because the dominant treatment system is something based in mostly AA and NA, which is based around Christianity. So drug treatment is not timely provided, does not provide freedom of choice when options are limited and the models being used are not diverse. Personal income determines what type of program someone might go to and enter. And it also might speak to what they receive support after treatment through. So sometimes someone might go to a treatment center for free, but then they have to pay for the aftercare, which could cost them thousands of dollars. And then they wouldn't be able to do the aftercare because they can't afford that. So having ongoing support and counseling after leaving a treatment program is fundamental, and a publicly funded system should be offering this free to people. It shouldn't cost people like $30,000 to go somewhere for a month. People who use drugs come from a range of socioeconomic backgrounds, racial, ethnic groups, sexual orientations, gender, and engage in substance use in different ways. So people need actually access to what actually works for them that recognizes the diversity of people who wants that support. And a major challenge with today's addiction treatment system is this reliance on these outdated systems. So, you know, harm reduction shares a basic understanding of substance use and shares underlying principles and practices. And I'm not going to say that harm reduction is perfect. It's also band-aid solutions on a gaping wound. But the basic premises are universally understood amongst those who work in the field, that harm reduction is about reducing the harm associated with drug use and drug prohibition without the cessation of using. And it recognizes we'll never live in a drug-free society, and our approach should be non-judgmental and meeting people where they're at. It's also a practical response to preventing disease transmission and overdose prevention. So the case for drug treatment, which does not have a universally accepted definition of addiction, programs can vary depending on the philosophy of organizations and their definitions and understanding of quote unquote addiction. And this can be confusing and harmful for those who are accessing the systems as they go from program to program, which differ in philosophy and understanding. And the disease model doesn't allow for people to have different explanations of their use, which is also problematic, while others in their life are other things could be helpful and not problematic. Having no standard of definition also means that those who are working with drug users are determining whether their use is problematic by definitions we do not have consensus on. And so I also think that it's depoliticized from the politics of people's everyday lives, seen as compulsive behavior and not influenced by systemic and social structures that impacts people's lives. It is completely valid for people to feel their substance use has been influenced by others. I've worked over my lifetime with many people who struggle from deep-rooted pain caused by childhood sexual abuse, from the impacts of colonization, residential schools, the 60s school, from the violence of everyday life, the loss of culture, loss of family, being displaced, dislocated from their communities, or from working their injured bodies to make a living. And it isn't always the drug itself, and drug treatment and healing should reflect this. And this is the point I want to make, which goes back to the speaker prior, was just, we're talking about putting community resources into community wellness and well-being, seeing people as like whole beings. Now we have so many people that have died. I have worked with people whose whole families are now gone, and loss brings more loss. And I've seen that even amongst my own friends and family group, where people have felt the brunt of grief and not been able to like heal from that, and have also died afterwards. And so our system is quite antiquated. People hold multiple identities, and so drug treatment is mostly focused on the one identity, and that's the person as an addict. And I'm speaking to this because we rarely actually critique the system, and we've come to accept its myth that it's working. Thousands of people are dead, and their deaths are telling us a story. And that story for many can be connected to a system that isn't working. Like going back to the people who accessed healthcare days before they died. What were those interactions? What kind of healthcare were they actually trying to access? So when we think of a patient experience and a future changing, we need to be one that is not latching on to outdated ideas and siloing people with Western notions of healing. We actually need one that sees people as full human beings who should have a say in what their healthcare looks like and what it is they actually need. And for people who use substances, this is just not always the case. And we're not thinking about, it's just lacking intersectionality. It's negating the structural and systemic oppressions and other root causes. We have a problematic system that goes unregulated, profit motivated, incentivized, and use models that have no evidence base. And for it to be effective, it has to be evidence informed. And that evidence can just be like what people know to work in their own communities. I think of land-based detoxes as an example of that, and how exceptional those have been for people, and Indigenous people. So, there are questions that need further exploring, like what are we expanding? What models are we using? And the models that are using, are they expanding? Are they harmful or effective? Alberta has a whole recovery-oriented kind of philosophy where they want to add more beds, but what kind of beds are they adding? What are those programs? Are these programs beneficial? Is there a standard of practice? Are there medical people on staff? And are people to have access to like their own religious and spiritual beliefs? And so further research, would be good to be done to further examine and look at this correlation between absence of all substances and the relationship to overdose and overdose death. Because at this point, we're not going to end the crisis of death if we're not willing to examine like all facets that have been contributing and not working. And I say that as someone who, has buried many people, lost a lot of people, that, for us to really like, we can build safe injection sites, and we can talk about safe supply. We can end prohibition, and decriminalization would be a great place to start. But we also need to think about when people need help and support, what does that look like? And how do people get the healing that they need, and that they're listened to as a whole person? So thank you.
Zoe, wow, thank you so very much. You've given us a ton of information, and thank you for the work that you do and for sharing, because it's not easy and you do it every day. And even retelling this is, I just can't imagine it's coming from your heart. You can tell, never mind the amazing information that you shared with us. So thank you. I can't wait to come back to you with Q&A. And I'm going to turn it over to our next panelist, Dr. Sadev, to give us his perspective from the oncology community. Dr. Sadev, I know you have slides, so if you need any help, just let us know, but it looks like we can see them, so thanks. I'll turn it over to you.
Yeah, can you hear me okay?
Yes, perfect.
Oh,
Thank
fantastic. It actually works. Thank you. I'm Sandy Sadev, a medical oncologist. I am now in Ottawa, but for 25 years, I worked as a general oncologist in the Toronto area. And for about a year or so, actually in the States before I came rushing back, because I was quite unhappy with the inequities in care back in 91 in the USA. We'll talk a bit about how that's affecting us now in Canada after COVID. So there's a great document on the website by CPAC, the Partnership Against Cancer, looking at various aspects of how COVID has affected us and how we need to improve things now coming out of it. So I won't go over these in detail again, but kind of they're summarized in this kind of recovery document. I'm happy to share my slides, by the way. I made them last minute, mostly to provide some structure to my ranting and to keep you from having to see my face for too long. But I did actually learn a lot by preparing them. So if anyone wants the slides later, it's just my last name, sadev@mac.com. So I'll talk a bit about different aspects, particularly in solid tumor oncology, how COVID has affected us and what the challenges now are now sort of coming out of COVID. So what about breast screening as an example, perhaps the best example of the impact of screening testing and early detection? So this is data from the Ottawa area. So in Ottawa, the number of screening mammograms in 2019 was 2,166. And you can see the drop by mid-2021 to 1985. There was also an increased gap between scans because of lack of access, shutdown programs. There were the reminders to patients stopped from government, and the annual detection rate went from 5 per 1,000 scans up to 8. There are more cancers actually being picked up because of an increased interval. The detection rates actually doubled from 34 per 1,000 up to 77. The number of cancers per month has recently started going up. And the number of cancers picked up by screening actually has gone down. So more of our patients coming in now are coming in with lumps they can feel or the doctor has felt. Those are almost always a more advanced stage. We've had issues with capacity for screening. We're caught up now with the numbers we do per month in the area, but we've not caught up with the backlog. So in the Champlain area, including Eastern Ontario and Ottawa, this is the number of overdue mammograms. So within the high-risk screening program, we've been keeping up pretty well, the red bars, but the annual and biannual studies, now there's a deficit of 28,000 that are waiting in the queue. So this sort of illustrates the impact on screening. We have not been able to catch up the backlog. This is perhaps even more of an issue on colorectal cancer screening, where my colleagues that treat colon cancer say we're picking up cancers now at later stages also. So what about mental health? This is a kind of a summary of the impact of mental health, of COVID-19 on mental health of healthcare practitioners. And I just sort of summarized to say that, oncology is perhaps one of the most multidisciplinary fields in medicine. We work integrally for every patient encounter with nurses, pharmacists, radiology, pathology, home care, and we're seeing this across the board. I think the public thinks we're coming out of it now, but there's still a lot of instability in staffing, not knowing what your shifts are going to be like, not having personal time for family, being frightened to take the virus home to your family or to bring it to your patients. There's been a huge rate of burnout. There have been quite a large number of retirements and resignations in the last year or so facing oncology. What about for patients? Well, particularly for the elderly, this was a nice review from British Columbia in current oncology on the impact on older patients. And I see this every day. Their quality of life has been reduced. They're often holed up. They're still afraid to go out. They're at multiple hit points for higher risk of death from COVID, age, immunosuppression by cancer and cancer treatment. They really long to see and play with their grandchildren. It brings them to tears talking about it. They have trouble getting out to maintain social relationships with friends and family. So this has been a huge issue for us, and we're not by any means out of that yet. What about clinic visits? This was a publication from late last year from Manitoba, also in current oncology. I'll just walk you through it. So the black lines are what we would have expected in terms of numbers if it had not been for COVID, and the red lines are what we actually were seeing. So the number of cancer surgeries actually went down. The number of chemotherapy visits did not go down. I think once a patient is diagnosed with cancer, we were able to maintain the flow of cancer treatments. The number of radiation starts did not go down, but the number of fractions of radiation per month did. What that means is that radiation oncologists were able to modify their regimens to give a bigger punch of radiation per zap, but fewer numbers of visits. So save the patient coming in so often with the attendant higher risk of exposure in the hospital. That's something we can learn from perhaps moving forward out of COVID. Overall, the number of in-person visits went down, but the number of total visits was not decreased because of the, luckily, the availability and funding by government for virtual care. In Ontario, the number of screening tests we talked about before plummeted during COVID. It's starting to come back up again. Mammograms are in the orange. The number of treatment consultations, so how many new patients we saw in radiation in blue and medical oncology in black, did dip and has come back up again. And the number of treatment visits also had dipped as we were avoiding chemotherapy, avoiding some treatments, but now that's coming back up to the baseline again. What are the factors that maybe accounted for treatment delays in starting cancer drugs? So this was actually quite important, I think, and illustrates the points raised by previous speakers, but the delays disproportionately affected minorities. This is from the States, but Black or African American, Hispanics had a much higher delay in starting treatments. And relative to breast cancer as a reference, there was a greater delay for blood cancers, gastrointestinal cancers, and lung cancers. So those patients, lower socioeconomic status, smokers, for example, also had increasing delays in access. In terms of how cancer patients compare to non-cancer patients in the healthcare system overall, this was a nice publication from Massachusetts in Current Oncology. Cancer patients in the pink had basically just as many delays in their access to testing and treatments as non-cancer patients. Often cancer is prioritized, but not really overall. There was less of a delay in diagnosis or screening because other things that weren't felt to be as urgent probably took a bigger hit. In terms of virtual care, the access and use of virtual care went up pretty much equally in cancer patients, more to phone visits for oncology, but overall a huge number of increases in both areas. What has been the impact of virtual care? I spoke at this forum last year about the difficulty, people not able to bring their families for important discussions, for in-person visits, not having emotional support. I think moving forward, what we can learn from our experience is that it is a very good option to have virtual care, even if COVID was gone, for discussions like lab results, scan results, reassurance for patients. Patients on active treatment, where we're just asking about side effects or conveying blood test results that it's okay to go ahead. Discussions about patient questions that may not be serious or reflecting any dangerous new symptoms. But if they have symptoms of concern, we need to see them in person. If they're new consultations, we have to see them in person because we can't really judge their strength and their fitness for treatment over the telephone. What about guidelines? Just to make a point that we rapidly developed guidelines in every jurisdiction, the UK, America, every province in Canada, to deal with the pandemic when it started in 2020. How to prioritize visits, how to triage people, if we had shortages of staff, how to decide who gets treatment and who could be delayed. And what I took from that is that we can really collaborate effectively and rapidly when we really have to, when push comes to shove. Our bureaucracies in Canada are notoriously slow and non-responsive, but we can do it if we need to. And I think we need to maintain that flexibility, not just in terms of handling pandemics, but handling any new challenge brought forward by new advances in therapy. We have to implement quickly and do it collaboratively internationally and within Canada. We've not been good at that before. What about clinical trials? Well, the clinical trial numbers actually dropped substantially. The numbers of patients recruited in the middle of 2020, and they had picked back up again. And I think clinical trials, even in programs where they were restricted, they did prioritize cancer trials. The total number of trials, however, did go down substantially. The last gray bar is 2020 to 2021. At least in Ottawa now, they've picked back up again. So luckily, we are doing better. There was initial paralysis. The trials coordinators were not allowed to come in-house, and patients were often reluctant to come in for the more frequent visits, tests, et cetera, that were required on clinical trials. What are our learnings? For systemic therapy coming out of COVID, we've learned that we have options for bridging. If there are delays in the future, delays now faced by resource issues, we're still having trouble with OR time delays, staffing in the operating room, we can bridge people safely for breast cancer using hormonal therapy, for example, to tie the cancer down until they have surgery. We're also good at prioritizing who should go first if we have a pinch. For chemotherapy, we know when there's a situation of immune dysfunction, infection risk, we have to optimize supportive care, maintain immune function, encourage patients to have vaccinations, to mask, even if the law says they don't have to, encourage their kids, grandkids, and neighbors to mask on their behalf. We want to prevent emergency room visits because the emergency rooms are just strapped and they can't handle it. It's also taught us the importance of capacity. Now we're facing huge capacity issues. We still are not up to full steam with staffing. And we've learned how we can outsource less intensive therapies, including some supportive therapies, non-chemotherapy treatments to family doctors and infusion clinics. What about radiation? Well, if you're giving radiation, and we have data before that you can do breast adjuvant preventive radiation in 5 shots instead of 30, and the results are equally good, why don't we go that way in the future, just in terms of cost effectiveness, patient satisfaction, and less visits? What about inpatient care? COVID really taught us the importance of family. When patients are sick, only the sickest patients are admitted to hospital in oncology. They're often there for quite a while. They suffer. They suffer from loneliness. They died alone. It was heartbreaking for the staff to see that happen. So somehow we really have to prioritize linkages with family, friends, social contacts while maintaining infection control procedures. And perhaps lastly, we've learned a lot about teamwork. Healthcare is now in a catastrophic circumstance across the country. I am afraid to break my ankle. One lady you may have heard about in the news broke her hip in the Ottawa area and was in a hot summer garage for 8 hours waiting for an ambulance. Sometimes the closest ambulance in Ottawa is an hour west from Renfrew. No matter what happens to you, you have to wait an hour. So we are really in a difficult situation, and we need to work as a team to help meet those needs. We've never more appreciated the role of family physicians. They often would provide home visits, palliative care, counseling. When they could not do that in person, it was really hard for our patients. They often provided bridging in terms of symptom support, and that still is quite limited. We already faced a massive shortage of family doctors in most urban and suburban settings and rural settings in Canada before COVID. And as you've seen in the paper in British Columbia, Ontario, everywhere, this is now at a crisis stage. As I mentioned before, oncology is very multidisciplinary. We have massive backlogs in radiology. Perhaps the most frustrating thing in oncology now is if we have a patient that needs a CAT scan every 3 months to see if their cancer treatment is still working, there's no guarantee that'll be done. Sometimes the scans are a month or 2 late because they just haven't got an opening, or the people are driving 3 hours away to get a scan. Pathology reports are taking a week or 2 longer to come out, affecting patient care. Pharmacists are behind and don't have the time or capacity to build new advanced regimens into our computer systems. And home care. During COVID, it was really terrible. Patients were hospitalized for longer than they had to be because there was simply no home care staff to take care of them. So with that, I hope I painted a bit of a gloomy picture, but maybe a bit of a formula for what we should be focusing on to come out of this. And I look forward to our discussion. Thank you for your attention.
Thank you so much, Dr. Sadev, and you gave us a lot to work with, so thank you. As usual, we really appreciate your perspectives. And I'll just turn it over to Rachel Mannion, who is next on the panel.
Thanks, Antonella. And thank you very much, Dr. Sadev, for your presentation. It's very eye-opening when you hear from folks who are on the front line about what is happening. I'm just going to share my slides, and it looks like they are working. So please let me know if you cannot see them. So I think I want to just kick things off by thanking the organizers of today's event. This is a really unique event that we have here in Canada, and I'm delighted to be here to share some of the perspectives from the skin patient community. I'm the executive director of the Canadian Skin Patient Alliance, and we are here to support people who are impacted by more than 3,000 different conditions. So it's essentially anything you would see a dermatologist for. These are conditions that affect the skin, the hair, and the nails. And I can tell you right off the bat that skin patients, which is sort of a catch-all term that we use, skin patients face many barriers. We have different kinds of communities within the skin patient community. So some people live with chronic skin conditions. Examples of that would be eczema, psoriasis, acne. And then there are several different skin cancers, melanoma being the most well-known. And we are in good company today here with Savior Skin Foundation and Dr. Sedev and others from the cancer care community. There are also more than 1,000 known rare skin conditions. So depending on the type of skin condition that you have, you're facing a different kind of set of barriers. Across the board, we know that stigma and discrimination are dominant experiences for folks who have these kinds of conditions, regardless of whether they are chronic in nature, whether they are skin cancer, or whether they are rare. And we know, because we are humans in the world, that stigma and discrimination can impact our mental health and also impact our access to care and optimal treatment. One of the things that is sort of a common refrain for people who have different skin conditions is, it's just a rash, it's not going to kill you, with the exception of perhaps melanoma. That is something that people often hear. And so their experiences, their concerns, and their needs are often diminished, dismissed, and disregarded. When we look at what different parts of our community have faced before the pandemic, we know that there's often a diagnostic odyssey. Access to healthcare in this country, even before the pandemic, really depended on where you were and sort of it was a bit of it often felt for people a bit of the luck of the draw. So getting that proper diagnosis can be really challenging, and it can be really challenging in different ways depending on what part of the skin patient community you fit into. So for skin cancers, for example, just sort of picking up on Dr. Sedev's talk, we know that path to getting a diagnosis for a skin cancer can be long, confusing, and we know that there is a lot of work that needs to be done there. We're very happy at CSPA to be engaged in the work of All Can Canada, which is led by Savior Skin Foundation. So if you have questions about what that odyssey is like, please do check out the work that they are spearheading on that. That diagnostic odyssey can look different if you have a rare condition, a condition that is versus a condition that is more commonly known. But even between something that might be very common, like eczema and psoriasis, it can really depend on who is in front of you making that diagnosis. We would hope that the average primary care provider would be comfortable distinguishing between those two very common conditions. However, that's not always the case. I know myself, I was always diagnosed with one, and then this year it turned out to be that I had the other once I was able to see a dermatologist. Access to dermatologists, I should say, really varies in the country. I think we have 8 dermatologists in the province of Saskatchewan, only 4 of whom are currently seeing patients. That's what I understood the last time I checked in on that, versus I live here in the downtown Ottawa area, and access is a very different picture here. So for those of us in the patient community more broadly who need to see a specialist to get that diagnosis and to have ongoing care, it really depends on where you live, and it really depends on whether you have access to a primary care provider who's willing to make that referral. When you live with a chronic skin condition, this is the case for inflammatory conditions. You can often experience flares. You can have a psoriasis flare. You can have an atopic dermatitis flare. And when that happens, that can really, what that is it's an acute period of disease worsening. And that can pull you out of work. That can mean that you have to change your medication. That can mean that all of the lifestyle changes and everything else that you have put into place in order to manage your condition kind of goes out the window. It can exacerbate your comorbidities. So for example, if you have psoriasis, you have about a 30% chance of also developing psoriatic arthritis. There's a lot of overlap between other conditions like HS or hidradenitis suppurativa and other kinds of inflammatory conditions that can affect the musculoskeletal system or the digestive system. So often when you're experiencing a flare, which is that increase in inflammation in your body, you're experiencing that in actually more than one way. This kind of gives rise to a lot of thinking that we've been starting to do in the past little bit around episodic disabilities and how we can make sure we're properly supporting people so that they can deal with periods of disease worsening, so they can continue to live their lives, they can continue to participate in their social lives, in their work life, in their family life. And I think you're going to hear from everybody today about how mental health support is really critical. So, and then along comes the pandemic, and we experience increased stress and demands on individuals, reduced prevention education. Dr. Sadaf touched on that as well, in terms of routine screenings, and shockingly increased isolation. And I know we've all lived through this, so I won't belabor it. But when those specific impacts for somebody with a chronic inflammatory skin condition, stress is a big trigger for a lot of inflammatory skin conditions. So that can bring out itching, pain, worsening of the actual integrity of the skin. When we had reduced access to healthcare providers, that means that we can't always get referred to a specialist, and then we can't get the diagnosis, and then we can't access prescription products that are the most optimal treatment for us. We also saw the explosion of virtual care, and so for the skin patient community, there's sort of some interesting repercussions on that. So when you have a visible condition, you might think that being able to, that might be really useful, and you'd be able to use virtual care, especially in a video setting, kind of like this that we're doing today. You might think that would set us up in a really, really good way. But a lot of the diagnoses that are made for skin patients are more than a visual diagnosis. That's a really, really key part, examining the skin, the area around where the disease is presenting itself, and being able to touch and feel and use proper scopes and things like that, specifically in skin cancer, being able to use a dermatoscope, which kind of looks a little bit like opera glasses. It's something that dermatologists will use to help distinguish between different kinds of cancers. So that could be the difference between a diagnosis of melanoma and non-melanoma skin cancer, for which the treatment pathways are completely different and the urgency associated with care is completely different. So when it comes to virtual care, we know this is here to stay. We had to do some learning really quickly, as we all did, anybody who interacted with healthcare. And as there were decreased options for people to access healthcare providers, more and more people were showing up at emergency departments when they were in crisis. So then they're faced with the question of, well, how urgent are you? Are you going to die today, right now, if you are not treated? And for many skin conditions are not imminently fatal. And so a lot of that care gets pushed back out to the community. People find themselves in a vicious circle. So that was a lot of the sort of dominant experience during the pandemic. We know when it comes to access to treatments, and again, I'm speaking generally because our community is quite diverse. We know that there was reduced access to phototherapy. So for those of you who aren't familiar with phototherapy, that is a form of light therapy, and it is typically delivered in dermatology clinics. So you go to the clinic, you have your session. You usually go multiple times a week, and it's used to treat psoriasis, it's used to treat eczema, it's used to treat cutaneous lymphoma, it's used to treat a whole bunch of different conditions. So at a certain point, especially early in the pandemic, those treatments were just not available. Nobody was running those phototherapy sessions. And so what that means for people is that means that their treatment stopped. Often people who are pregnant or who have a variety of other contraindications for some of the other more tailored therapy options, phototherapy is what they use. And so when that was discontinued, they were not able to get their therapy at all, their treatment at all. We know that at the broader level, we saw there were a lot of administrative delays. So somebody who had a flare who needed to switch to a different product to manage the flare and then come back maybe to their original product, that could take 8 weeks. Meanwhile, you're living in crisis during that whole time. We also know that we've seen backlogs, I beg your pardon, backlogs and bottlenecks in that review process. When it came to outside the healthcare system, this is one of the points that I really want to make here. For people who were immunocompromised, so that could be from a cancer treatment, that could be from a treatment for a chronic skin condition or a variety of other conditions, they were really afraid. People who were immunocompromised were really afraid throughout the pandemic. And so when we think about where we are today, the flip side is that people who are immunocompromised, now that everybody has sort of collectively decided that the imminent threat of this virus is behind us, because that's kind of what seems to be what's happening across the country, people who are immunocompromised often feel really ignored. They're nervous to go to the grocery store because nobody's masking. They're nervous to go to a party or a baby shower or something like that for the same reason. So we want to make sure that we aren't creating a system as we go back to normal, or whatever language you want to use, where we are not ignoring a segment of our community and we are not leaving them to fend for themselves, especially when they are particularly vulnerable. The only other, one of the other points that I just wanted to flag for everybody before I wrap up is that we are now seeing, as services sort of come back online or have been coming back online, we're seeing waits start to increase as there is a greater demand for these services, as everybody waited and waited and waited until they felt safe going to their doctor or they felt safe going to the hospital. Now we have a lot of demand for services. We are confused about how to use virtual care going forward. We used it because we needed it, but was the way we used it the best way to be using it going forward? Maybe not. And that's a project that CSPA is going to be working on with the psoriatic disease community, including Canadian Psoriasis Network with Antonella Scali here today, to try and disentangle a lot of what's been happening. And I know Save Your Skin Foundation is doing a lot of work on that in the cancer context too. So those are some interesting areas for everybody who's interested in that to continue to pay attention to. When we talk about creating a better future, we know that we need to improve access to care and access to treatments. We know that when we look outside the healthcare system, we want to make sure that public health policies are protecting vulnerable people. And I think that all of the people who are here today and who might be watching this later, we all have a role in doing that. We all have a role in asking questions of decision makers and policymakers to ensure that all of these policies are inclusive and inclusive of people who may be immunocompromised or older or have some other kind of vulnerability. We also want to make sure that we are advocating for a really broad perspective on what is disability, so that as people are trying to continue to live their lives and experiencing all of these changes that are happening in the healthcare system, they can continue to be supported and they can continue to have access to the resources that they do need to. I'm looking forward to the Q&A, and I'll stop there and I'll pass things over back to you, Antonella.
Thanks so much, Rachel, for those excellent insights that will be great for discussion at our working groups, and really appreciate your perspective. And I'm going to turn it over to Laura and just quickly acknowledge that we are running a bit over time, but we will take some time from our working session. So hopefully the gang can stick around for Q&A a little bit later, but thanks, Laura. I'll turn it over to you.
Hi, everyone. And just to be clear about time, I want to make sure that we do save time for questions. So my goal today was to talk a little bit about how do you actually get from here to there? How do we actually make sure that we're making public policy and driving forward some of the questions that we've seen prior? So we know how important it is that we do synthesize the work that we're doing, that we do make sure that we are trying to move forward in our goals. So I thought that what we would do is talk a little bit practically speaking about some of the work that we've been doing at CanAge, and then I'm hoping that you'll be able to take some of that great information away and use it to the best of your abilities as well. So in this, I'm just going to talk a little bit about how to make yourselves into public policy rock stars. And what I mean by that is how to make sure that you're getting the great information that we've been hearing from organizations, from patient groups, but actually get it into practice. And I'm going to give a couple of quick examples of our work in both immunization space, which we talked about a little bit before, but also in the dementia space. So just 2 seconds. And this is important because I'm going to talk about why you should introduce yourself in a certain way. My name is Laura Tamblin-Watts. I'm the CEO of CanAge, which is Canada's largest seniors advocacy organization. And that's it. That's how you introduce yourself. Our key issues that we talk about are what we call our voices of Canada's seniors, which you can certainly see here. And what we also do is we talk a little bit about how to do good public policy as well. So what I'm going to do in 10 minutes is try to help talk a little bit about translating your ideas into policy, how to make sure that your pitch is going to be effective, and also what to avoid when you're trying to move forward. So when I talk about a policy, we're usually talking about identifying a key problem, and we're trying to figure out for that 1,000 type of organizations that are working on skin, how do we move that forward? When we talk about the myriad organizations that are looking through cancer, how do we move that forward? Or if we're talking for an even bigger bucket, perhaps all patient groups, how do we move that forward? Then the advocacy is the actual doing of the thing. And I usually talk about 2 levers. There's one lever where you can pull yourself. So I can get up in the morning and take my medications. I may need some reminders. I can eat right and exercise. Yeah, I know we're all supposed to eat right and exercise, but I have the ability to pull that lever myself. I may need some help, support, reminders, debriefing, but I can do it myself. The other kind of advocacy is where you have to get a third party to be persuaded to do what you want them to do. And so I usually think about advocacy as kind of branching that idea of policy on the one hand with marketing and communications on the other. So whether it's doing a public awareness campaign, whether it's creating images, or whether it's driving our healthcare providers to do X but not Y, it's all really that third party advocacy. And again, advocacy is often working within that sphere. And so we're hearing from community groups. We're trying to often persuade government. Many of us will have seen the challenges that even the premiers were having in discussing with the Prime Minister and the Federal Minister for Health for whether or not dollars would flow for healthcare and what that would look like, or how it would be tethered, or in the case of the premiers, they don't want it tethered to funds. So it's pushing and pulling to see who gets that piece. I want you to have a look at the picture on the right. This is a real product, and many of you will know it. They are hip airbags. Yes, we know that falling is one of the worst things that can happen. We know that if an older person falls and breaks a hip, their chances of dying in the first 12 months is about 20%. Yeah. And within 18 to 24 months has risen to almost 40%. So we can do a bunch of different things, but said researchers, what if we put airbags on their hips so they didn't break? Good idea in practice. But, you know, the issue is clear. How do we stop people from falling? And there was research, these hip airbags would work. Not so much with the consultation, because it won't surprise you that nobody wanted to wear them. And many people said, I'd rather break a hip and die than walk around with these things. So when you're thinking about going through, this is the top 10 things about creating your work. Have one specific issue, not a whole bunch of things. Make sure that you've done your homework, of course, and that you have gone into any meeting having got proof of your consultations, and if possible, proof of a sign-on. And that's why when many of us send letters to each other, we say, would you sign on? It's because we're going to government or a third party, whatever that is, and we need to show that people already agree with it. Try to figure out which switch is it. Is it something that you are trying to mobilize individuals to do? Eat right and exercise, take your medications? Or is it something you're trying to persuade the third party to do? Have a clear clear, narrow, specific ask about what your solution is. We want 3% of the healthcare budget. We want every Canadian to be able to access 5 hours of home care, whatever it is, crisp. Know the cost, find out who your critics are, and make sure that you're going into whichever third-party policymaker you're doing and use their language. So make sure that if the discussion is about cost cutting, you're going to talk about cost cutting. If your issue has got something to do with aging in place, make sure that whatever you're talking about, including an eczema coverage, is about aging in place. And acknowledge if there's other alternatives that can be done. Here's how you do it. Hi, my name is Laura Tamblin-Watts. I'm the CEO of CanAge, Canada's largest seniors national advocacy organization. I'm here today to tell you that we need to increase the funding for dementia from X to Y. The problem is, this is all the information about dementia in one little bit. The solution is what I am saying. And we know that people are concerned. And so these are what some folks are saying, but we know that success looks like this. So again, I'm here to ask for 10% of the health budget. Thank you for your time. Here's some additional information that you can use. You should be able to do it in 5 to 6 minutes. And that's all the attention they have. But when you're doing it, have a story and make it personal. If you can kick off after the ask about doing that, it makes a really big difference. But try to avoid them talking about their parents, their mother, their whatever, except for a very short period of time. If they are going to talk about it, that's fine, but make sure that you're able to say, yeah, your mother's story isn't alone. Her getting shingles is a huge part of this, and then go into explaining why it's bigger. So again, the most important thing you can do is find out who the government or third party is and find out what their agenda is. But the most important piece is get the name of the booking person. The booking person who is actually running the calendar of the person is actually maybe the most important person. And the civil servants don't move so much. The MPs or MLAs or ministers that you're talking to, they move around a lot. And people often think we need to talk to the minister. No, usually you need to talk to the civil service. Make sure that you've done a good Google search and figure out where they are. Policy cycles and budget cycles are hugely important. So right now we're starting to talk about things like vaccine purchasing because we need it for next year's flu season. But Laura, you say, isn't it just flu season now? Yes, except for the fact that the budgeting will happen in January, February, and the orders will go in February, March. And then after that, by May, it's too late to order more vaccines for some things. Here's your pitfalls to avoid. Don't talk too much. Don't go on about who you are and how many people you serve and what you do. They don't care, not really. One line and that's it. That is one of the biggest mistakes people do is they talk all about whatever the condition is, or they talk all about whoever you are. Skip it. Very, very tailored message and be interesting if you can. Make sure that your words are crisp and that your timing is on point. Again, very little information. Here's a quick example of some of the ways that we were able to use our policy acts to make big change, and this really did. So this is a cross-country comparison. Visuals about how Canada is doing on adult vaccinations are very persuasive. And if you're going to have a specific spotlight, pull them out so you don't use too many words. You can show comparisons between other jurisdictions. This is really important. This is one of the reasons that we're getting BC to move up, is because we know that they're competitive with Ontario. And we're able to say, you know, BC is the only jurisdiction in the country which does not fund X, Y, and Z. Most places don't know how they're doing against other jurisdictions, but care a lot. Our most recent report was on dementia in Canada, and we wanted to see, you know, how are we doing? And you think that that's an obvious thing to ask, but actually nobody had ever done a report trying to measure it out. So this is, again, one of the most important things I can tell you. Measure things. And you'll see some of these different indicators here. One pediatrician for every almost 2,900 children versus one geriatrician for almost every 21,000 seniors. And that number is becoming even more the case and more dramatic. So being able to show some key things, which you can do as a leave behind, is important. And then making sure that, we didn't put in 40 pages of text anymore. We took them out because we know that people can compare these things very quickly. There's a lot of medical data in here, but people can actually work their way through it very quickly. And then we had some key asks. This is what we asked for people with dementia. This is what we asked for caregivers. And this is what we asked for healthcare workers. And so what I'm hoping that you got out of this very short review of how we do on this issue is, don't spend too much time introducing yourself. They don't care. It's not important. If they care, they'll care at the end. Start with your ask. Tell them what you're there for. Crisply explain why it's important. Then, have a bit of a story, or start with a bit of a story, but don't let it wander. And then make sure that your information is visual so that they can't take in too many numbers, but make sure that they can see it. And then finish with the ask. And then make sure that you ask for a follow-up meeting with somebody. And that, I hope, is how you can become a public policy rock star, and how you can take everyone's important issues about moving dynamic needs forward and putting it in a way that can actually make change. Again, identify if it's one type of lever where you're trying to get people to do good things for themselves, or a third party. I'm really happy to share my slides. There's no problem with that. And I'll make sure that the folks do it as well. So I'm going to turn it back to our moderator for questions. Really happy to talk about either our vaccine report cards or dementia reports or any other specific work you do. But I was hoping I could teach a little bit about how to do it right and what to avoid when working on moving your policies forward.
I'm agreeing with everybody in the chat, Laura. That was amazing and very succinct. And we gave all of you panelists a tall order to put such important information in a very short amount of time. So thank you so much for getting us started to actually look at this from a practical lens. Like, how do we actually turn this into action, some of the stuff that we've heard about and the work that we're doing. So I want to invite the other panelists back. If you're still here, that's amazing. Thank you so much. We do have only a few minutes, but we're going to take as many questions as we can. So if you have questions for the panelists, please do put them into the chat. But one thing that I wanted to ask, based on Laura's presentation, and maybe we'll start from Zoe and go through everyone in order, is from all the great information that you shared with us, is there one thing that you want to see happen? And you may get asked this a lot, but that you really want to see changed. And not just that, I guess as an enabler, how can this patient community, this audience that's here today, help you and help your community create that change? And I know it's not an easy answer, but if you have an idea of our role in supporting the work that you've shared with us already, I wanted to open it up that way, Zoe.
I think that the overdose crisis has been going on for almost a decade now, and I think we're becoming a bit complacent and accepting of mass death. And I mean, we see this whether it was through COVID or we in those conversations about MAID, we're seeing more and more of like a kind of an attitude that people, some are deserving of life and some are not. And I think that is where we need to be talking, is that we are all deserving of life. And so that is something and also, we're in a crisis that doesn't actually have like tables. We don't have an emergency response table at a provincial level. I used to sit on it with government. When Ford took over, he got rid of that table, but it had many people from different sectors working together. We are not working together on these issues that are complicated, and that we do need to be able to do without massive political interference. We need to be able to talk. We need to be using data. We need to be using proper responses, or we're never getting out of this. Like, it is spiraled out of control. So I think part of it is to just keep it going, keep the, the numbers are staggering, but those numbers represent people. And so I would say that that's the focus, is we're talking about people, like keep talking about it being people. Yeah.
Thanks so much, Zoe. Dr. Sadaf, I'll turn it to you real quick if you have any ideas for us as an audience in terms of some of the oncology challenges you were sharing.
Yeah, perhaps even beyond oncology, but just to advocate, and it does actually help to actually contact your MPPs and MPs. They do actually get back to you and usually will listen to you. I would advocate right now for emergency funds to be created for human resources. BC created a new fund for family physician support. We need more family doctors urgently. We were way behind before. Emergency funds for diagnostic imaging. We're only, the fund that was created only meets a third of the need today, and we can't get scans done on anybody for anything these days. And in the medium term, I think support an increase in the federal government health transfer to the provinces. And I think probably at the federal level, argue that we should have conditions. I'm tired of that extra money being tossed aside into free license plate stickers and tax cuts. We have to have some accountability.
Thank you so much for your perspectives. And Rachel, I'll turn it to you for any thoughts you want to share.
Thanks very much. Sorry, my Alexa's interrupting us. One of the things that I think is really important as for our community, we need to see better interdisciplinary care. We need to see the dermatologist talking to the rheumatologist or talking to the allergist or talking to the oncologist. I think that that's really important. And when we are worried about another pandemic or some other kind of emergency, I think we need to have a better game plan for when care is delivered in the community. We had a lot of people in this country defaulting to hospitals, and that they weren't getting the care that they needed there because the hospitals were overwhelmed doing other kinds of urgent work, predominantly around the virus, but not exclusively. So those would be the two pieces that I would advocate for.
Thanks. And Laura, do you have anything to add to these rock stars from your perspective?
I have to say, everyone is a rock star. I just want to maybe give a little bit of a framing of what it's like to actually be on the other side of those meetings that we get. Okay. So it will not be unusual to have 70 appointments that day. That's a 7-0. That the meeting will start at 6 in the morning. You've probably never seen any of the briefing materials because yesterday you had 70 appointments and tomorrow you have 70 appointments. You're probably traveling or you're on Zoom, plus you've got whatever else. So mostly they're coming in never knowing who you are. And again, don't take the time to explain who you are, one sentence, and that's it. And don't worry too much about what your disease is or what your worry is. 1 minute and give a little bit of a story. You have to be able to hook them, and being as precise and narrow as possible is important. So don't try to sell them on how important the overarching issue is. I mean, they have a million overarching issues and they are weighing off, the war in Ukraine with your meeting. They are weighing off the need to buy subs because there's more subs at the West Edmonton Mall than there are in the Canadian Navy. They are weighing off a pandemic against what you're talking about. And so unless you can actually flow it into what their biggest worries are and be a solution to a stated problem, it's not actually going to meet. And that's just because that's the situation. Like you can't make it. It's not any different. That's why it's so important to develop relationships. Ask to meet with the chief of staff, build up from the director of policy, and create good relationships. They have reporting requirements. Be a good reporter. Make sure that they get things, and when they want to share things, become a trusted supporter. Mostly that's what you need. Mostly the meeting with a minister is a pretty nice thing to do, but is not actually that important. So let's try to make sure that you're actually getting where you need to be by giving those good relationship supports at the beginning.
Fantastic context and reminders, and thank you so much, Laura. We have a question, couple of things. So we have time for maybe the one more question and then something for everyone. This is for Zoe. Thanks for critiquing many existing addictions care models. Are there more effective models of care for people who use substances?
I mean, I think that this is we need a really big overhaul of the system in general so that it is meeting the needs of people. And we need to look at different models that are not as archaic. Some of it we need to invent ourselves. So I worked in the Toronto Hep C program. I helped to start it. We treated people who are living with Hep C who actively use drugs. It's a support group. plus people get cured for their hepatitis C. And what is exciting about that program is that people come every week. We don't focus on substance use, but people's substance use starts to kind of like diminish, or they change patterns because we're focusing on them and their overall well-being. So I think there's like models out there that can be quite effective and useful, but I do think it's been a neglected part of our system for a really, really long time. And then there are models like the Indigenous healing lodges and the land-based detoxes. I mean, these are amazing, and we could use more innovation like this when it comes to addressing substance use. We've really stuck to the same old when it comes to like opiate substitution therapy and the way that it's delivered, really in a kind of punitive way. It's not really working effectively. We hadn't even had changes to our methadone guidelines, like in the age of fentanyl. So, 2010 was the guidelines. Then during the pandemic, they were getting changed and they've reverted back. So there's just so much that's a big system. There's a big system problem, but we need some serious commitment from people at different levels. So, yeah, it's not an easy answer.
And the point that you brought up about the data around, people having a medical intervention just days before they died of an overdose is striking, and it should wake us all up to how poorly we're using the information we do have, and how much more infrastructure we need around good data that's actually, guiding the work that we do. So, and you all talked about, data being an important piece, and Dr. Sadab about how things were shifting, so people were responding to the needs during the pandemic. So there are opportunities there. I wanted to say we got some feedback that the speakers are really wonderful. They're learning so much from this forum. Is it possible to get the slides? If you're all okay with sending the existing slides, we'll do that. And just to follow up on that question, if we do have any other questions that come in from the audience over the next few days, we'd love to be back in touch with each of you. But we do want to respect your time and give an opportunity for the groups to come together and really think through some of what you've shared with us. We've got the rest of the summit to dig deep into some of these issues that you talked about, including how we do advocacy together. So we hope that you all on this panel could join us for some of that as well and share your amazing work and perspective there too. So thank you with all our hearts for coming and for all of your great work. And I'll turn it over to the breakout sessions now. So thanks for everyone who can stick around for that.